Good morning, good afternoon, and good evening, digital health people around the world. We are really happy to have you here with us on this beautiful day in July to jump into all of the big things that have happened in the diffusion of digital health across the United States and around the world. My name is Stan Kichnowski. I'm the chair of HITLAB, and I am thrilled to welcome you all here to this month's summary of where is the evidence in digital health adoption and what is being worked on, what is being developed, and what is being deployed, and what is actually working, what is not working. And today we have an extraordinary agenda lined up for you all to start sifting through the tea leaves of digital health and understanding what's happening. One of the major validations that HitLab has done over the last couple of months has been with a company called MedsEngine. And Dr. Doug Romer, MD, is going to be online in a few minutes, walking you through what they're doing and how they're doing it and how they're changing lives and improving lives all over the country with their new platform. After that, we're going to dive into one of the leaders in America when it comes to digital health, Paul Testa, who's the Chief Health Informatics Officer at NYU Langone, who'll be walking through a little bit of how they are driving innovation and transforming NYU through digital innovation. Then through the first hour, we're going to talk through Dr. Lisa Fitzpatrick, another major validation HitLab has done with what Grapevine is doing and how they're changing lives and helping patients all over the country with improved information about what works and what doesn't in healthcare. And then at the 11:40 mark, we're going to have Paul Saunier, really the founder of digital health, the entire movement and the entire ecosystem about 15, 20 years ago, when he worked with Eric Topol to really rebrand digital medicine into digital health. And Paul's going to be talking to someone, a leader from Mount Sinai Health System, and hearing about what the future of patients looks like with specialty pharmacy and helping improve the connected patient beyond the hospital. We're going to be finishing out just the first hour with our own Jerry Antimano talking with a leader from AbbVie about what's happening with data and how AI in healthcare in life sciences is changing patients' lives for the better by using data. And then hour number two, we dive into a lot more of this month's theme around the digital pharmacy and how AI is changing pharmacy activities and patient activities at the home all over the country, all over the world. And then hour number three, we wrap up with a lot more evidence and evidence analysis of where is the evidence of adoption with everything from how innovation and AI is working within gene therapy and manufacturing, all the way through what's happening in Korea and how a Korean company called Medical AI is coming to the United States and also making lives better for Americans all over the country. And so that's the agenda for the day for the next 3 hours. We're hoping to have you all on board. Don't forget to subscribe to our YouTube channel so you continue to see all the good content and all the good analysis of the evidence of what is actually being adopted in healthcare. To kick us off is our favorite doctor when it comes to MedsEngine and what they're doing with helping improve patients' lives all over the country. I'm handing it over to Doug Romer, MD, to talk about what MedsEngine is doing and how it's helping patients. Doug, it's all yours.
Well, thank you, Stan. I want to thank the HitLab team for allowing us to participate in the digital symposium today. Dr. Doug Romer, family physician for 36 years, here to talk to you about MedsEngine. Our goal is basically to control up to 4 chronic diseases, and that's what we'll be talking about today. So jump right in. So one of the challenges in managing the 4 major chronic diseases is that there's guidelines that are long, they're extensive, they're great, but they're very difficult to follow. Typical example, hypertension, the #1 killer in the world, 37 variables, 214 pages of guidelines that we're supposed to know and follow. If that's not difficult enough, let's add the other 3 chronic diseases that we deal with. So you can see in diabetes, 35, cholesterol, 77, and heart failure, 11 more variables, but these are all going to be very interactive. If you then begin to look at all the pages in red on the right, there's an awful lot of pages that physicians have to know extensively to get guideline-directed medication recommendations. So what MedsEngine does, it actually looks for all 160 variables and utilizes all 855 pages of guidelines to provide guideline-directed medication recommendations. But the key here is we do this in seconds. Why is that important? Because now I have time to have a really high-value conversation with patients. So these pictures are really going to be quite significant. I'm trying to get to that situation in an exam room with a patient versus searching and finding things in the EHR and trying to figure out what the guidelines are actually saying. I got the guideline recommendation. My only job is to have a great discussion with my patient about what's happening. So visually, what is MedEngine? Once again, the picture becomes very important. This is very personalized in the exam room. It's you, your patient, and the EHR that you happen to be using. So we are an EHR integrated clinical decision support application. As you can see, it's very real time. These are going to be very personalized medication recommendations because it's based on everything that the patient has, very evidence-based. And the key here, once again, is we're doing this in seconds so we can have that conversation. So we provide solutions. This was built in the real world by clinicians for clinicians. Very user-friendly, saves times for both physicians and APPs. From a population health standpoint, becomes a very powerful tool because we can rapidly assess these particular chronic diseases and give excellent guideline recommendations. Also, it actively involves patients in the understanding. And this is going to be very, very important because when patients understand their disease, they understand the severity, they understand why that medication is going to be personalized to them, medication adherence goes up dramatically. This makes them very happy. So a lot of satisfaction with this. And then from a quality enhancement standpoint, once you begin to control any chronic disease, it doesn't make any difference. Things are going to change. If your reimbursement is based on star ratings, HEDIS scores, UDS scores, they're going to go up dramatically. If it's based on shared savings, value payments, once again, it's going to go up dramatically. We're not paying for all the bad things that are no longer going to begin to happen. Plus, from a quality standpoint, we use a uniform process to provide that consistent long-term care approach. So this is going to keep going on for a long period of time. So let's briefly take a peek of what you would see. If this is a version of your EHR, it doesn't make any difference. Once you sign on to your EHR, you're already there. You have MedEngine available. So it's a very much single sign-on. So if you're sitting with a patient, you decide you're going to work on one of those 4 chronic diseases. Once you push that yellow MedEngine button, what happens is the following. Step 1, you just push the button. Step 2, a message goes up into the Microsoft Azure cloud where MedEngine resides. It then sends a message back securely to the EHR to say, hey, can I please have those 160 variables? Does not enter the EHR, request those data points. Those 160 variables then go back up in the cloud in step 3. Now it's going through the 855 pages of guidelines. It rapidly comes back in stage 4 where you're going to have the picture in the discussion with the patient, which is key to this particular circle. That picture in the middle is what's going to happen. And all this can be done, get to that point in about 10 seconds. So that's going to be the key here. What about results? Does this thing really work? Well, today's actually a pretty big day for us because about 10 days ago, we found out that we have a new peer-reviewed evidence-based article that was released by the American Journal of Medicine. Why is it important? Because we're demonstrating 90% blood pressure control in primary care. This is a very high blood pressure control number. The significance is this was based on 14,000 patients in 2 separate groups in the US. We have 10 years of data. Also, the key here is we're using ICG hemodynamic data to use to guide us in blood pressure medication recommendations. Our goal for this has been a goal of less than 140/90. Of significance, the Pri-Med group in Dayton, Ohio, 92% blood pressure control rates by the 2nd visit. The group in Pittsburgh, 91% blood pressure control rates by the 4th follow-up visit. So we're doing this very, very rapidly. So when you get blood pressure control, what do we really want? We want lower MIs and strokes and other things. So we demonstrate much lower MI and stroke rates in the subset of patients that we followed, 3,000 patients for 7 continuous years. Also important to understand is that blood pressure was controlled at 88% of 53,000 follow-up office visits. So if you came in for anything, we checked your blood pressure, whether it was for blood pressure or for a cold, 88% of the time that blood pressure was maintained. Also, the other significant part to this is that's an inexpensive, hyper-scalable solution to achieve the new AHA-ACC blood pressure goal of less than 130/80. So we now have a tool that can really help us meet a more difficult blood pressure goal. Let's go into what this really means for patients and financially. So chronic disease control is cost control. Risk reduction with a 10-point drop in systolic blood pressure. So if your blood pressure is 140/90, we're talking about that 140 number dropping down by 10. I won't be elaborated, but take a look on the left. There's a large decrease in a lot of bad things from happening. So that's going to be quite significant. Also, look at the value that can be generated when you're not paying for major adverse cardiovascular events, strokes, heart failure, etc. Significant savings are going to be there. Also in the paper of significance, Pri-Med physicians had a systolic blood pressure drop of not 10 points, but 22 millimeters of mercury. The premier group, 18 millimeters of mercury. And we actually have better numbers on the left than we currently are seeing right now, which is a 10-point drop. Why is it important? Uncontrolled hypertension to controlled, you're going to save about $2,500 per patient per year. If you look at what we do in diabetes, we go from uncontrolled to controlled, $2,000 per patient per year. And then a study came out about a year ago by Johns Hopkins simply says if you can control cholesterol according to the guidelines, which are very difficult to follow, you're going to save about another $780 per patient per year. So there's quite a lot of dollars that can be saved in value contracts. This is going to fast forward to the medication recommendation page that you're going to see with the diabetes module. And I wanted to show you a quick example here. It doesn't take much for a patient to figure out that, gee whiz, I got 3 dots here. They're in a red area, probably not real good. With diabetes, what we like to simply do is spell it out. We're likely causing damage to heart, arteries, eyes, and kidneys. If you get into the yellow area, it's reduced harm. Ideally, the green area is where we really want to go. On the right, they can clearly see it's them. So that's going to be quite significant. The other thing is the ADA has been begging for years that we generate a personalized A1C to avoid over and under treatment of patients, but it requires 35 factors to know and find in the EHR, and you have to do the calculation. So in essence, it's not being done. We can do this once again in less than 10 seconds. So now we have a personalized A1C for every type 2 diabetic that's going to be out there. So the other part, the American Diabetes Association obviously wants to shift from those rigid targets to a personalized goal because it's going to reduce costs and increase the quality of life. So we're going to avoid the harms of over and under treatment. The other part is they want personalized medication recommendations that go beyond just lowering blood sugar. They also want to address the specific comorbidities. So we're going to suggest or recommend medications that are going to do both according to the ADA guidelines. Also, for all these modules, we have a print patient summary button so they can take this home, read through it, a lot more detail. So if I spoke too quickly, they can still understand that. Last but not least, what about payments for these types of things? So let me just go into briefly star ratings and HEDIS measures. These particular scores, blood pressure, statin therapies, glycemic status, kidney function, we can make a huge difference there. Medication adherence is going to be huge. Because of the understanding, it goes up dramatically for cholesterol, diabetes, and hypertension, and especially statin use in patients with diabetes. If you look at these 8 measures, 5 of these are triple weighted, so quite significant savings if you're into star ratings and HEDIS score reimbursement. Value payments are often going to be the biggest form of doing that. So if you're doing shared savings, that's going to be great. However, if you are still doing some type of fee-for-service work, there's a code out there, G0446, which is cardiovascular risk reduction counseling. It's hard to do this because of the documentation of work and time. We simplify this dramatically using MedsEngine. There's significant reimbursement by the major insurance carriers throughout the US. So if you simply do a single patient, you do the service, you bill this, it can be a $25 reimbursement. By the way, Medicare recognizes as something that's not being done enough. They bumped up their payment to $31. I didn't mention the MedsEngine cost, but said it was inexpensive. It's 45 cents per participating patient per month. So we're talking $5.40 a year for all 4 modules that we're going to begin to use. So this is a cup of coffee a year. So basically, it's $20 per patient. If you have a set of patients, adults, 2,000 patients, and you just screen half of these annually on an annual basis, essentially, eventually, you're going to get fee-for-service payment of about $20,000 per physician, and that's on the low side depending on the volume that you see and the payment that you're going to have. So that's MedsEngine in a nutshell. If I can help in any way, please let us know, but I greatly appreciate the opportunity to share our work with you. We appreciate this. Thank you.
What a loud round of virtual applause we are getting from the audience. Thank you, Doug. That is a fantastic presentation. Really appreciate it. Next up, we are really excited to continue the conversation around what's happening with digital health and digital pharmacy, and talk about a little bit more about one of the major health systems in America, NYU Langone, and what they're doing with medication management through digital innovation. With me today is the Chief Health Informatics Officer, Paul Testa. Paul, great to have you here today. Thank you for joining us.
Thanks so much, Dan. Pleasure to be here.
And again, if you could, let's start off with just a little bit of your background and tell the audience a little bit about what you do at NYU Langone.
Sure. Excuse me. So I'm the Chief Health Informatics Officer for NYU Langone. I've been here for about 22 years. I did my training in emergency medicine here, and I had the privilege of jumping over to health informatics about 12 or so years ago with our first large-scale re-implementations of tools, including the EHR. And currently, my role is to sort of rationalize informatics across all of our domains, that being education, research, and our clinical endeavors. In particular, our journey to a learning health system in the time of AI, and sort of how that is a new journey for many. So I get to sit over in between the worlds of the clinical applications, the research, and the education.
Which is fantastic. And a big part of that really covers data, right? And so if you could tell us a little bit more about how your data strategy leads into having a better clinical decision support for your clinicians.
Ooh, great question. And one we're pretty proud of. So our data strategy is one that dates back probably at least 18 or so years, that being with our prior Dean and CEO, Bob Grossman. When he first came on in that combined role, he likened it to flying a 747 without a cockpit. So ours is one of 900 to 1,000 defined metrics at a health system level, with probably 100 or so dashboards that we all access and live and grow by. How about that? Live and grow by. That was a commitment to a singular data warehouse and robust data architecture that, as we brought on new systems, including Epic, fed into that. In addition, our educational data warehouse is also in that. The most recent evolution of that is a full enterprise-wide commitment to Databricks as a platform, both for our being able to collaborate externally, as well as our internal data structures and our data, our 18 or so different data models that support different departmental and clinical needs. But we really have a singular structure at an enterprise level, which is incredibly important as a 12 million plus or minus lives covered, with about 3 million ambulatory encounters. All of that feeds to a single place, which Databricks is our primary tool at this point.
All right, that really does bring it to another level for you and your team. And let's talk a little bit more of that. Everyone's talking about AI these days and how AI is transforming everything from how patients access their healthcare to how they're getting better information online, to how organizations are using AI and certainly their automation in analytics to improve and drive better decision making and improved accessibility and quality. Talk a little bit about what you've learned about that and how other organizations can really leverage these points around AI and analytics to improve quality, accessibility, and affordability.
That's a big one. It's a big question. I appreciate it. I think what I've learned in our, we've been on the journey since 2017 with the predictive analytics unit. Everything was accelerated 36 or so months ago. I know for all of us, with the open accessibility of these frontier models. We've had some, we have about 150 or so models in production right now, a combined list of things we've built, things we've acquired, and things we've co-developed. We probably have a backlog of about 170 or so similar in that space. What does it take to do this right? It takes disciplined data, a respect for the workflows, that is the clinician and the patient's digital experience and how they inform each other, and workforce capacity to change. That is a workforce that understands that change is not necessarily a risk, but an opportunity And that is a cultural reality, as well as expertise, subject matter expertise. We had this team that we've been building up since 2017 that are deeply committed to how we assess models, grow models, equitably and responsibly deploy them in the governance we've set up. We are beginning to, I would say the medication management wasn't the first easiest spot to go. And even in the clinical realm, yeah, there's a lot in the workforce space, from acquisition to contracting to granting. But we have begun to deeply explore what it means to time to therapy. And in particular, we have a tool that we're learning a monumental amount with around remote patient monitoring, medication adherence, and how do we get patients time to therapy, for example, hypertensive patients, where we're nudging and engaging with SMS in those patients in their remote patient monitoring for blood pressure. Lots of lessons being learned. But similarly in the clinical setting, there's a lot about human in the loop. And is that a transition state? And what does it look like to infuse, sorry, no pun intended, to our pharmacists. What does it really look like to be a pharmacist 5 years from now? And is the best use of the cognitive abilities of those colleagues reviewing and validating order cues? Or are we being thoughtful to not recreate older systems, which may be really reminiscent of what a prescription is? How do we have that cognitive ability, that expertise, own exceptions while automating the vast majority of work?
That's amazing. And that's so absolutely incredibly important too, since so much of what we're seeing with the adoption of AI and analytics and a lot of the real world data is coming up on a lot of different barriers to those implementations. And the implementation science, at least from what we're studying at HITLAB right now, not just in the United States, but it's around the world, it's a global issue, is coming into focus as one of the key issues with the diffusion of digital in healthcare and life sciences. What are some of the barriers that you're seeing within these realms of AI and data aggregation and quality management and informatics and analytics relative to those implementations, and what are you doing to help get by those?
So we're a large academic teaching center. So our obligation is to generate knowledge that we can disseminate to drive change, regulatory and practice. In current state, there are ways that we can do rules-based auto verification, but we are constrained appropriately so. This is not me complaining or railing against regulation. This is the regulations exist from an informed state. As we generate evidence of the opportunity, we have an obligation to disseminate that and to engage regulatory entities around what can we, for example, remove from verification queues of our clinical pharmacists and our partners, both in the pharmacy, in our inpatient units, and on the floors. How many hundreds of flushes can we move from a particular verification queue to get that validation queue to really own the exception, right? So I see a time, but I need to generate the proof that it's appropriate and disseminate it and build a consensus that there are thousands of patients being auto-verified / monitored, with the exception of the verification queue, not the verification queue itself. I think we might argue that the deadliest medication error is the dose never given. That says the headlines, I got my start in healthcare with the adverse medication event at a cancer center in Boston, where I was the attorney doing the evaluation of the event. Those two events were picked up 6 months afterwards as the data was being used for publication, right? we've come a long way in those 22. That was in 1995. We've come a long way to monitoring of that. But that adverse event still shapes who I am as an informaticist, where it was the simple failure to divide by the number of days. We can no longer expect retrospective analysis to inform how we define work queues moving forward. I would offer we have world-class telemetry around our pharmacies, right? We know the temperature of a vial on a truck 1,000 miles from here. But that last 50 feet, up until closed-loop administration in an inpatient setting, the highest monitored setting, is the best we have. So how do we extend that awareness? How do we extend that telemetry to the home? How do we extend that telemetry? And we have the tools to begin doing that.
Yeah, let's double click on that too, Paul. I think you're really diving into an important issue, which is, around this idea of not just healthcare operations, but also clinical workflows. So from what you've seen now, how can AI, how can digital technology improve these important functions around that, whether it's logistics or clinical workflows, and where are the best opportunities there?
I think the experience we are having right now with pairing remote patient monitoring and medication titration for those who have yet to reach therapeutic windows is the place we're gonna first prove our worth. Right? So what are some of the? It's interesting when we talk about remote patient monitoring and medication adherence and management and titration to therapy. It seems like too often, like, well, that's it may eat into our margin. It may provide incrementally quicker time to care to therapeutic window. I'm suggesting that is where we're going to prove our value. That is where we're going to prove our worth. We have patients. So we have a cohort of employees. Those are a great place to learn from, who are non-controlled hypertensives. Let's give them scales. We all have them on the same EHR, and that's what we've done. And we have about 100 or so that we can nudge and engage with their compliance, their adherence, their therapeutic regime. But we can't do that at the expense of the pharmacist and physician and nurse managers who are then flooded with blood pressure values. The exception should be what is escalated. And we're working on understanding with legal compliance and regulatory, as well as our clinical teams, what it looks like to have an AI chatbot helping our patients get to therapy and knowing when to escalate those abnormals to a human. I think that the human in the loop is a transition state. We have to prove our worth to get through that transition state. It is not a destination unto itself. But right now, we are all comforted by saying out loud, human in the loop. We now need to generate the evidence that at some point, these models are more performant than we are. And that is going to be a moment of reckoning for me as an ED doc and my clinical pharmacist colleagues and my primary care docs that I work with very closely.
Yeah, and this has been phenomenally insightful. And let's wrap up with more of a future-facing question around where you see this all going for medication management and safety. And again, double clicking on that human in the loop factor being a transition state. Where do you see this going over the next 3 to 5 years then? If we're in a transition state right now with human in the loop, where are we going to be 3 to 5 years from now when it comes to medication management, the logistics and the clinical workflows and the safety features around that?
Sure. Well, my crystal ball is not the greatest, but what I see in the short term or the intermediate term is that full automation is our health equity strategy. Right? Again, I want to anchor on the most risky doses of the doses never given, though headlines will tell us otherwise. And those never make the headlines. But they do provide for a community of well-managed patients. So we have to, I'm going to not to repeat too much, but We are in the process of generating the evidence that suggests anomalies are escalated, but automation can handle a monumental amount of medication management and adherence. And in the safest fashion, it's that anomaly ownership by the highest licensed individuals that will get these patient populations in an equitable fashion to therapeutic, the therapeutic dosages, the therapeutic moments, be it via remote monitoring or otherwise, in the fastest way. Because frankly, it cannot take, in this day and age, 6 to 9 months to get somebody appropriately managed their blood pressure medication, for example. That's just one example.
Paul, can't tell you how much we appreciate your time today. Thank you so much for joining the HITLAB community around the world, and particularly here in the United States, for helping folks understand how to better operationalize AI, informatics, analytics in their hospitals and their health systems to improve outcomes, affordability, and accessibility. Thanks, Paul.
Always a privilege. Thank you.
And we have a lot going on today, everybody, and so looking forward to the rest of the next 2.5 hours. And don't forget, for those of you in the HITLAB community and for those of you who are not in the HITLAB community, to register for the HITLAB Summit. The early bird savings are winding down. Tomorrow is the last day to register and get the cheapest price you're going to get between now and December 1st. And we're looking forward to seeing you all in New York City, December 1, 2, and 3, to review all the evidence that you can imagine from everywhere from the last summit that happens at the end of each semester, first week of May, first week of December, all the way through December, and listen to papers and posters and presentations about, and interviews, panels, workshops, roundtables about where the evidence is showing for investors and buyers and where it's not showing, where we're seeing things really not hitting the adoption scale as fast as we'd like. And we know it's validated technology. We know it's good technology. And what can we do to give it a boost? So don't forget to register, get the early bird savings. And next up, we are thrilled to have Dr. Lisa Fitzpatrick, also known as Lisa in the Street. Dr. Lisa in the Street is a program that's been running for a few years now and has reached tens of thousands of patients around the country to help health plans and health systems better understand, better get messages to their patients with having Dr. Lisa Fitzpatrick talking to patients literally on the street. Lisa, thanks for joining us today. And if you could start off by telling everyone a little bit about your background.
Sure. Hi, good morning, Stan, and thanks for having me here. But first, a correction. It's not just me who's on the street. We have a team of doctors, and they're not all from Washington, D.C. So just to clarify, it's not a one-woman show. It's a movement we're building. I'm an infectious disease doctor trained in public health and epidemiology at the CDC. I worked there for about 10 years. And during my time at CDC, I started adding qualitative research or data collection to the quantitative research we were doing in the field. And that stayed with me because I learned so much about the context for the data we were collecting. And so really understanding what's going on with people, what their concerns and fears are when it comes to health, and at that time, public health. I took that when I left CDC into my work at an academic health center and in my work running a clinic. And we continue to ask people about the context. And so I think this is an area that we have neglected far too long to really understand what all the data mean. And also we use a lot of jargon in healthcare, but we don't take the time to really understand if we're effectively communicating with patients and community members. So once I left my clinical position, my administrative role, I became the chief medical officer for DC Medicaid and continued to express some curiosity around how people were using the healthcare system, what their concerns were. And I would say over the last 20 years, all roads lead to trust and health literacy, helping people, the need for people to have a trusted resource to help them navigate the language of healthcare, the systems. It's very complex for people. I'm going through this now with my parents who are both navigating the healthcare system, and I just don't understand how people do it without a helper. So Grapevine Health is here to be a helper. We create relatable health content, as you mentioned, Dr. Lisa on the street and other doctors on the street. And the reason we've chosen this mechanism is because we've gotten a lot of feedback from the community about, and even now in the age of AI, people still appreciate the human-to-human contact and the human-to-human connection and instruction or demystification of health information. People really still want that. And I've had people send me their chat GPT or their Claude responses and say, well, what do you think about this? So there's still a need and relevance to human interaction. And the speaker before me mentioned this as well. So I think it's important for us to keep this all on the radar. And that's what we're trying to do at Grapevine Health. So providing these bite-sized, relatable health information, video content for people is showing to be really important and necessary.
No, it's fantastic, Lisa. And I think, a big part of HITLAB's validation of your platform showed that the engagement is extraordinary. You're able to engage with patients through talking with other patients on the streets, whether it's you or the team of other physicians that are on your platform. Talk to us a little bit about how that engagement translates to better medication management, better persistence, et cetera, with patients and their medications.
Well, first, I just want to acknowledge the work you all did with us at HITLAB to help us validate the importance of what we're doing. And to me, the most important finding, in addition to all the things you said, was that was true. People found value in what we do, regardless of their educational background. And related to that, people were asked if they understood the issue we were presenting the videos about. So the videos were about colon cancer screening, and just about everyone, whether they were college educated or not, said they knew about colon cancer screening. But at the end of that, watching the videos, the post-assessment showed that everybody learned something and saw value in the videos, or just about everybody. So I think we really value the work you did for us, because it will really help us communicate about the value of what we do. With respect to clinical outcomes, this is a road ahead for us to really generate a cohort large enough to demonstrate that this matters. So we have a lot of anecdotal evidence. We also have some data from our payer engagements that show there's a signal that our communications outperform whatever the baseline engagement is. And so we just need to continue down that road so that we get the kinds of measures and outcomes you're talking about. There is one piece of data we've been able to accrue around digital engagement and having people reach in after engaging with Grapevine to say, please help me get an appointment. And as you probably know, this is the holy grail for payers. There are many people who are not engaging, they're not responding to digital outreach. And we've been able to demonstrate that people are more likely to engage with Grapevine content because it's interesting and relatable to them.
Yeah, and I think one of the big things that we're seeing across the ecosystem as well is this idea of engagement translating into outcomes. Talk a little bit about that in terms of, again, the program today is around medication management. How does that improve outcomes when people are more engaged through your programming and the programming and the messaging coming through with other physicians on your platform, engaging with patients one-to-one? How does that translate into better medication management and overall better outcomes?
The first and most important thing is that people can understand what their medications are and why they're taking them. And I think we don't spend enough time really trying to understand this, but really the drivers of non-adherence, in addition to cost, if you were to prioritize the reasons people have trouble adhering to medication, cost is usually at the top. But right beneath that is trust and not understanding whether or not the medication is important and what the medication does. So I'll give an example. We encountered a woman who had been prescribed Lasix, which is a diuretic for her blood pressure. And she never took the medication, and her provider became very frustrated with her. So we explained to her what the purpose of Lasix, what it was actually doing in her body, because her frustration was that she had to go to the bathroom too frequently. So when we explained the reason for being on Lasix and what it's doing to her blood pressure and her long-term health, she started to take the Lasix. And I think these are very basic, fundamental things we need to consider, but I think it seems too basic to really matter. But what we're showing over and over again through communicating with people about things like their medications and medication adherence is that you can move outcomes. And it may not be on the immediate scale people would want, but it matters.
It matters a lot. And I think one of the reasons why the evaluation that we did of the Grapevine platform were so important was the ability for the platform to reach underserved populations. Talk about what you do in that area and how it makes such a difference to these communities.
The biggest way it makes a difference, Stan, is trust building. And we talk a lot about trust also in healthcare, but we don't get concrete enough to really understand how trust or distrust is really driving costs, outcomes, patient experience, patient engagement. Trust is at the root of all of it. So when someone encounters a Grapevine doctor, especially someone on the street, we hear things like, wow, I've never seen a doctor on the street in my neighborhood. And they think a lot about, well, what are the implications of that? This person understands me. I trust that person. And I've had people tell me, wow, I trust you more than my doctor. My doctor has never explained things in that way. So, we can't continue to be dismissive of trust and the role it plays in engagement, and particularly in medication adherence. Stan, I don't know if I've told you, people often call us drug dealers. And sometimes it's in jest, but sometimes it's from frustration because they perceive that our primary goal is to prescribe medications and make money. But again, if you, rather than be dismissive of a criticism like that, really embrace it, lean into it. And this is where the qualitative work comes in, and ask, tell me more about that, or why do you think that? Or I can see how you would come to that conclusion that we prescribe more drugs than we should, but here's the reason why. And then you can have a conversation with people, and this also builds trust. So the pandemic taught us a lot about trust in underserved communities. And frankly, before the pandemic, we knew all of these things because there are so many reasons people are distrustful of our healthcare system, the way they're treated, the level of condescension or dismissive people encounter when they're poor or when they're from a racial minority background. So I think the work we do will continue to shine a light on the importance of trust in healthcare and the need for us to get concrete and hold each other accountable for addressing trust and distrust in healthcare.
Lisa, this has been fantastic. As always, great to have you on the program. Looking forward to hearing more from you in the future. And thank you so much for bringing your clinical knowledge, your health system knowledge, and your knowledge of how to work with patients directly on and with patient populations in the streets with you and your army of physicians. And we'll looking forward to hearing from you again in the future. Take care.
Thank you, Sam.
And next up, we are going to continue to dive into this idea around pharmacy and medication management to improve healthcare, but doing so through these digital technologies, life science technologies. And we're really excited to have one of the co-founders of Digital Health. It's very rare when you get to say that. And the person who founded the digital health community on LinkedIn, Paul Sanye, on board to interview yet another phenomenal leader in the U.S. and global health system. Handing it over to you, Paul.
All right, thanks, Stan. Appreciate it. And hi, Mark. It's great to have this opportunity to learn about your work at Mount Sinai Health System. And thank you for accepting my connection request on LinkedIn and for joining my digital health group, as Stan pointed out. So I think, as many of our viewers today probably know, maybe heard about this event from my group. A lot of them are members. I founded it back in 2009. It's now about 117,000 global members, CEOs to clinicians, you name it, every stakeholder group. 2012 is when I initiated the global adoption of the term digital health. I didn't coin the word or the phrase. And then these days, I'm now Chief Growth Officer at Blockhaven, and we're building the Health Intelligence Network. It's a new foundation for health organized around the individual, giving people a lifelong health memory they truly own. It's very unique. But I'll spare you the full pitch. Today is about Mark. So I'm delighted to be speaking with Mark Mackinson. He's Senior Director of Outpatient and Specialty Pharmacy at Mount Sinai Health System. His work spans the full continuum of health system pharmacy with a focus on connected, high-performing pharmacy models, and where care delivery meets technology, from AI-enabled patient engagement to remote monitoring and scalable digital care. Mark, welcome. I'm really glad you're here. Our topic today is the future of outpatient and specialty pharmacy, connected care beyond the hospital. And it's a timely one because more and more of care is happening between visits, well beyond the hospital walls. And Mark, why don't we just dive in now? What do you think?
Thank you, Paul. Thank you.
Great. And your audio might be a little low, or my speakers might be a little low.
Yep. Sorry about
Okay.
that.
So,
Can you hear me now?
much better. Thank you.
All right.
So great, Mark. Thank you again. So as Senior Director of Outpatient and Specialty Pharmacy, how are digital technologies transforming specialty pharmacy services and improving patient outcomes across the care continuum?
Yeah. Well, again, thank you, Paul. Thank you, Stan, for having me today. Very excited to talk about this topic. I'm very passionate about the evolution of digital pharmacy, especially within the specialty pharmacy space. In my role here at Mount Sinai, right, I've overseen several different kind of innovations over the past few years in AI as well as just digital health. And as time goes on, right, as you said, right, and as all the other speakers said, the acceleration just continues to get faster and faster, right? So, I think right now we are in a place of change, just like the other speakers have alluded to. But where we're going is more from operating as a reactive organization to more of anticipating the needs of a patient and their medication needs and their therapy needs specific to the individual patient, right? Right now, we measure success in the number of prescriptions that we dispense on a daily basis, the number of patient interactions our clinical pharmacists have with our patients. I would like to shift that measure of success to what are the outcomes of the patients, right? And what does their adherence to the right therapy at the right time do to their overall health outcomes, right? I think that's the vision that we're going to be able to drive through digital and AI advancement, right? Taking away the back end, rote tasks that our people do and changing that to more of a patient focused approach.
Yeah, I think your emphasis on outcomes is key here, right? And that's what we're seeing across the spectrum in health and healthcare is everyone's looking at outcomes. So it's fantastic to hear that. So with that in mind, looking ahead, which emerging innovations such as AI, of course, is a big one now, really taking off as you alluded to, predictive analytics, remote patient monitoring, digital therapeutics. Which of these do you believe will have the greatest impact on the future of outpatient and specialty pharmacy in particular?
Yeah. I want to say all of them, right? I think specialty pharmacy as a kind of industry is relatively new, right? I believe the term was coined about 10, 15 years ago. Specialty pharmacy started with HIV medications, oncology medications, and has expanded from there, right? So we're a relatively new and really fast-growing segment of pharmacy as a whole. I
Right.
think right now we are in a state of, three different changes, right? The first being back-end automation. I think we are there already. We have been able to automate a lot of the tasks that were really time consuming for our people. So think about benefits investigation, prior authorization, financial assistance, right? Think about taking all of those tasks that somebody needs to do and automating it so that they are focused on reaching out to the patient and engaging the patient to their disease state. Right. So that's number one. I think that's current state. That's table stakes in 2026, 2027. You look a little further than that, right? We need to take this automation and digital enhancement to the patient, right? A patient's daily life is spent online, interacting with your choice of chatbot or LLM. They do it when they're shopping. They do it in their work. That needs to happen in healthcare. And we're starting to see that, right, with the integration of digital tools and AI into platforms like Epic. But it's nascent. And I think that needs to accelerate quickly for healthcare to stay in the same realm as the rest of the marketplace.
Mhm.
So I think that's coming very soon, and I think that will be very widely populated across the next year or two. And then the third piece is anticipation, right? Anticipating adverse effects, anticipating patient needs,
Right. Right.
anticipating financial burden for a patient, right? With Medicare deductibles changing year to year, right? How can we anticipate a cohort of patients that will need extra assistance coming into a plan renewal year? And how do we target those patients before that time so that they don't have a lapse in care that leads to poor outcomes? So I think that's the goal, in my mind, over the next few years, is to get to a place where we can anticipate a patient's needs in the specialty pharmacy space.
Right. And that really resonates with me and the work we're doing at Blockhaven, is bridging the gap between episodic healthcare, anticipating, what may be happening and trying to intervene earlier. So I think that's fantastic to hear that from you and what you're doing at Mount Sinai. So in particular, in that regard, what strategies have been most effective in strengthening medication safety and adherence for patients, especially with chronic or complex or chronic conditions managed through specialty pharmacy?
Yeah, I think I would love to highlight an initiative that we're working on this year that's kind of pulling together many different sides of the health system, right? Historically, you had your acute care side, that didn't really talk to the ambulatory side, that didn't really talk to the network. We're
Right.
taking that and pulling it all together, right? So a patient that gets admitted into an acute care setting, right? They are getting a medication reconciliation upon admission, and
Okay.
we're starting to think about discharge at the point of admission, right? So
Mhm.
our pharmacy care teams are integrated into the larger care team for the patient. As soon as we have visibility into what the patient's going to need upon discharge, we are doing the back end work, the benefits investigation, the prior authorization if needed, any financial assistance, so that the patient can have medications in hand at the time of discharge. Right. So that's number one. That's going to decrease the length of stay, improve readmission rates. So once they're discharged, then they are in the ambulatory space, right? So we need to ensure that they follow up with a provider, that they're not having any adverse effects on their current medications. So that's where our clinical pharmacists come in to ensure that, between their discharge and their first appointment with an ambulatory provider, there is some kind of care in between.
Mhm.
And then once they see the ambulatory provider, then we want those medications filled internally again, so that we can then monitor adherence, ensure that there's no financial toxicity, no barriers to therapy. and keep them within the continuum of care, right? So tying it all together so that the patient has a single source for any clinical questions and any clinical needs, and we can track that, is going to take us to that next level of predictive analytics.
Yeah, very fascinating. And I think we may have time for another question. Stan, I don't know if you're pressed for time, let me know, but I can ask another question to Mark.
Yeah, please. Yeah, another question,
Okay.
minute or two. That'd be great.
Okay, awesome. So Mark, another question I have for you is how can outpatient and specialty pharmacies leverage data, automation, and clinical analytics to optimize workflows while maintaining a personalized patient experience?
Yeah. We have so much data, right?
Mhm.
As a
Yeah,
health system, uh, pharmacy, right? We're integrated into the EHR. We're able to
right.
pull medical data as well as prescription data. So we have started mining that data to look for trends and to look for ways to better serve our patients and for them to have better outcomes. One thing I would highlight is patient identification, right? So taking the data that we have to identify patients that may be on suboptimal therapies, that are not getting the results that they want, right? So think about a patient that's on a cholesterol lowering medication, potentially a statin, potentially a PCSK9,
Okay,
but their LDL is still trending, above 190, above
right.
guidelines, right? How do we identify that patient and have a clinical pharmacist interaction with them, to ensure that number one, that they're adherent, that they understand how to take the medication and that they're taking it appropriately, and then secondarily have that pharmacist intervene with a provider and say, we identify this patient, we think that they're a good candidate for a different therapy that's going to drive better outcomes, right? I think utilizing the data that we have internally is so powerful, and we're just scratching the surface on what we can do to improve those outcomes for the patients.
Yeah, fascinating. Yeah, and I really love how you're implementing digital tools across the spectrum of what you're doing in specialty pharmacy. And like you said, it's kind of a new area in a way. So I think it's great. You're kind of at the vanguard of what's happening in digital health. So thank you very much, Mark, for sharing all this. Love what you're doing at Mount Sinai Health System.
Thank you, Paul. It's exciting and it's just the beginning. I
Yeah.
think that there's going to be so much more exciting innovation very soon.
Uh-huh.
Thank you.
Great. Looking forward to that. Okay, Stan, you there?
Yes, sir. Thank you,
All right.
Paul.
Yeah, my pleasure. Thank you again, Mark.
So
Thank
I
you.
think what we're picking up from here is just how much we're seeing the transformation of healthcare occurring in every different aspect, small, medium, large, even micro, across the ecosystem. And so to dive into that even further and talk a little bit more about how the next generation of R&D is going to work into medication management and pharmacy is HITLAB's own Jerry Antimano to talk with one of the leaders in this area from AbbVie Health, a major manufacturer and researcher and developer of medications for people around the world. Jerry, handing it over to you.
Yeah, cheers, Dan. Really good program so far in our first hour of our July Digital Health Symposium. And it's my pleasure to carry that on and go right into, as Dan was mentioning, the need for clinical intelligence for the next generation of clinical development. And who better to talk about that than Aman Thukral from AbbVie. Aman, welcome to the program. Good to have you with us. Really appreciate your time. We'd certainly love to hear a little bit more about the work that you're doing at AbbVie and a bit about your background before we dive right into the questions.
Thank you very much for having me, Jerry. It's an honor. Yeah, my name is Aman, and I sit within our clinical development organization. I'm a pharmacologist by training, but responsible for collecting data for all AbbVie clinical studies, transforming data, what we submit to FDA and other regulatory agencies around the world. And I think the theme is resonating with me since morning. One of our goal is to be more patient-centric. It's not a word for us; it's a meaning for us, and it's like what we embodied for nowadays. How can we be more patient-centric?
Absolutely, yeah, and I think that's really super important and something I think people don't really associate it with the life sciences community in terms of having a very patient-focused agenda. So it's really important that you certainly iterate that and make sure that the community is aware of that focus. As a leader in systems in digital operations, how is the clinical strategy driving smarter decision making, especially for patients across clinical development at the moment?
Yeah, our business is changing, our business is evolving. The new therapies such as T cell therapy or cell therapy or gene therapy, and that has created a brand new capability for us in terms of data custodians. Like, how do we collect data for these patients without burdening them? And um, we cannot just ask more and more data from our doctors. We call them PIs, principal investigators. So we are resorting to new avenues, such as, can we directly collect from hospital EHRs? That's one thing we are working on, so that they don't have to transcribe again in our systems. The word for this is direct data capture, or EHR EDC integration. EDC is our system where doctors enter data for the patients. That's one avenue. Then another key trend which we are observing is FDA and other regulatory agencies. They are very focused on nowadays on patient outcome data, which means we need to collect data from patients directly, how they're feeling, their quality of life. So that's another avenue which has evolved for us. Last but not least, another theme for us is, I think it has been discussed this morning, is a DHT, digital health technology. Nowadays, we are provisioning a lot of apps and sensors, Apple Watch to our patients, and getting that enormous amount of data is giving us so much evidence, which is opening other channels for us on how we can develop better therapies, faster therapies for the newer diseases and indications.
No, I think those are three really important points that you bring up. And being at an organization like AbbVie, I'm sure you work with many different organizations that are trying to also implement a lot of these strategies that you spoke about. In light of that, how can these different organizations in the industry leverage the AI, the automation, things like advanced analytics that are very prevalent nowadays to improve the quality and accessibility, and also interoperability, since this is a digital health symposium, around the clinical data. Also at the same time, while enhancing medication safety as well.
Absolutely, absolutely. So in my role, just to give you a magnitude, a very high level, at any given day, we collect data from 2,000 different sources. These are imaging vendors, lab vendors, hospitals directly, patients through their iPhones, they submit their quality of life. They're wearing these Apple Watches. And millions and millions of transactions we ingest every day. And my team's goal is, how can we convert this data to a standardized format where our medical reviewers within our company, or safety reviewers, or clinical reviewers, or data managers, they can review in a short amount of time. They can identify these anomalies. They can identify these, if there is any fraud or misconduct, and we can follow up with the sites and the doctors. I think that's our vision. We are leveraging a lot of AI in this. AI-driven data standardization, AI-driven data anomaly detection, AI-driven data transformation. So these are some of the use cases we are trying to modern AI. It has been remarkably, like, for us, the benefits are so high because we live in the data world, and the amount of anomaly detection, what we are doing today, with a very little force, it's exemplary. The way you know these AI technologies has made our work so easier for us.
Yeah, no, absolutely. And I know we're not we haven't got much time, and there's certainly more we can dive into. But I certainly want to ask you at least one more question. I encourage all the audience listening in to connect with you, Aman. We did put Aman's LinkedIn into the chat and more information about what he's doing at AbbVie as well. So please do connect with him. But before we ring off, Aman, I certainly like to look ahead to the future and ask you about emerging technologies or things that you've seen data driving wise in terms of solutions and platforms that are going to be most critical in shaping the work that you do around clinical operations and digital pharmacy, and especially patient-centered healthcare.
Yeah, I think we are at an inflection point of technology. My job is, can we transform the patient experience and the doctor experience, and can we do it faster? There are a lot of unmet needs. I'm in clinical development organization, so our job is to bring these medicine faster to these patients. So our whole predicament is, can we leverage these technologies and move fast? We are calling it study acceleration. How can we accelerate our clinical trial studies? Also, hugely beneficial for our patient community. I think there was a theme this morning. Can we give a 360-degree view of patient health, whatever we collect from them, their movement data, what they captured in the Apple Watch, their lab and imaging data, and some of their actual interventional data, which is collected by their physician. If they can get a 360-degree view and whether the therapy is working for them, is our drug efficacious, I think that's going to be a remarkable technology impact. It was doable in the past, but today with the modern AI and the evolution of new technologies, the unit economics is in our favor. Like, we can do it hugely faster and we can do it at like a fraction of the cost. So that's going to very positively impact our physician experience, our patient experience, and bringing these therapies faster to the market.
Some really amazing insights that you shared with us, Aman, in a very short space of time. And of course, we really appreciate the time that you spend with us. I know you're super busy. So, I want to thank you for coming on and sharing your knowledge with everybody. And I certainly want to encourage everyone to connect with you after.
Thank you for the opportunity. Honor to be here. Thank you again.
No, thanks so much. This is awesome. Okay, wonderful. And that brings us into the second hour of our 3-hour July symposium. And we're going to move right on to Rachel Trubman, VP of Product at Waddle Baby, one of the amazing HITLAB startups that we've been working with recently around infant care. And she's going to be holding a conversation with Dr. George Vermenten, around reimagining infant care with connected health. Rachel, handing over to you.
Thank you so much. It's a pleasure to be on the HITLAB stage again, and even more exciting to be joined by Dr. Vermenten. We've had the pleasure of working together over the past couple months now, and the work that he's doing in his practice in really creating exciting and meaningful and inclusive patient care is truly remarkable. So I'm going to I start by saying, when HITLAB first approached you, Dr. Vermenten, about introducing remote patient monitoring into your pediatric practice, what were your thoughts, and what actually made the decision for you to decide to start incorporating it?
So, first of all, thank you very much. Thank you for the opportunity to, talk with you and express a little bit of my gratitude to be involved in this project. So probably like around 9 months, probably around the end of November, you guys approached with this idea, which I found like really, really interesting because as a kid, I'm a pediatrician, right? I'm a kid in my heart. I used to watch the Jacksons, so usually I used to watch like the doctor doing like kind of a televisit. And you know that during COVID time, we had the opportunity to develop and also implement that idea. So it was pretty interesting to me that this type of devices can be used as a plus in primary care and also like in a hospital settings if you are like trying to push this forward.
And great. And as you began to use the Waddle, which for those of you who do not know, is a smart changing pad, meaning that we have an advanced precision scale built into the Waddle. As you began to start using it, what stood out to you clinically?
So to be honest with you, as we started like doing the process, it was super comfortable to me with a patient that had twins, and a patient with had twins, come up from the nursery. The patient is for you to come to the clinic is a big process, and sometimes in my population also it's a little bit costly. Usually you don't take the train to come with twins. You have to take like an Uber or a cab, right? So decision making, I decreased the amount of probably visits to this type of patients because it was more comfortable with mama. And usually the weight I was following with these patients, it was pretty close to the way that we did in the clinic. So it was pretty helpful, at least from that part in my practice and my decision making.
Got it. And was there any like aha moments where the platform or the solution changed or reinforced your decision making?
Like pretty every time the patient will come to the clinic, it was like, okay, this is pretty close to the weight that we can record. So I think I can trust this mom that is following the instructions and also is, giving the data back. So I think I'm gonna minimize the visit. If she has like any concerns, probably gonna trust more in her like view. Um, and it was something like that. That was probably the aha moment that it was pretty close and pretty accurate of whatever we were seeing in the clinic.
Got it. And from your perspective as a pediatrician, what makes a digital health solution truly useful given your busy clinical practice? And where do you think that some products miss the mark?
So in primary care, if you have like your private practice, one of the first concerns of the patient is patient waiting. Sometimes you have like a lot of visit that you supposed not to have in your clinic, and it takes time from the front desk, from your clinical staff and from the doctor to probably realize something that you couldn't be it couldn't be done at home. Let's say that you think that your baby is breathing funny, or you think that the oxygen saturation is off. Probably with these devices, you can, like, if the mom is well trained, that the mom that was working with us, the mothers that were working with us were, I think that can, minimize this type of visit that I unwanted in your clinic. Also, let's say that you are coming from the NICU and you have this patient that you're following because of weight, and you are trying to see if the patient is gaining weight for real. Instead of going to the hospital like pretty often, you can follow digitally. Also, patients that have failure to drive, usually you have to do like a weight check and calorie in and out intake in 3 days to see if it's something that the mom is doing wrong or the father is doing wrong. You can also follow every day, those 3 days. You don't have to wait for the third day and realize that the patient is not gaining weight, to make a decision.
And where do you think, if you have evaluated other digital solutions, whether they're hardware or software, whether they're scheduling all the way up to what we have with Waddle, where do you think there could be improvements? Like what, in terms of workflow or
So
clinical
it will, the
burden or
improvement,
education, where do you think there's opportunities for improvement, not just in the Waddle product, but what you wish you could tell all sorts of digital health founders?
so integrated in the platform, in the EMR and EMR, the integration, it will be something that if it's easy to integrate in the EMR and also cheap, that will be awesome. Another thing is probably the training of the parents. Sometimes the parents, like, when you set up something, sometimes you don't take the advantage, because we, as a human beings, I don't know any human being that will read all the instructions. So with these devices that are a little bit delicate, probably a person that goes and train them well, so you can take all the advantages of these devices.
Got it. And in terms of where you think there's opportunities for technology, whether it's hardware, software, AI, to make an impact in pediatric care, where do you think some of the opportunities are in terms of what pain points you see as a clinician and a
Oh,
practice leader? Yeah.
we are running through AI, so it makes things more easy. It makes things faster. I think technology and AI is the future. Probably in my practice, we implement AI basically for everything. It will give you like a hint, even though it's not something that probably is super accurate. So it will give you hints. It will like set up like alarms. It will let you know how the patient is, and even in your sleep, you can wake up and you will have like a message. Oh, I think you will check this. You have to check this patient, and you will go and probably schedule like a visit or a televisit with this patient, and it will be like super nice for the follow up. That is something that sometimes the clinician, because we manage a lot of patients, we may miss.
And one thing that you noted early in the conversation was really about accessibility for your patients, where your practice is located in terms of transportation, in terms of ease of access. What can you talk a little bit about your particular patient population and how maybe some of the challenges around technology, but also the opportunities?
Yeah, the challenges around this type of population is like the accessibility. Probably they don't have, the money to buy a device like this. So it will be awesome is if like the insurance may cover it. It will be like great if you have like the necessity of this device. If you are a premature, and we need to follow you closely. If you're a patient that is not gaining weight, I think it will be super awesome that the insurance can cover right away. Probably
Awesome.
not initially to everybody, but patient who has the needs.
Yep. And that's where like a lot of these remote patient monitoring codes that we've been
Yes.
using with other practices have come in handy because it is a covered service, especially in New York.
Yeah.
Um,
Other thing is, for example, patient that has had like any problem with any social issues, and he has like an ACS case and now have like a new baby, and you want to make sure that this mom is doing their job, also it can give you like that information.
Interesting. That's great. Is there anything else that we haven't discussed today that, it's been on your mind in regards to where technology companies are making and missing the mark when it comes to uniquely pediatrics?
Um, only the integration to our practices ourselves. Like basically in New York, to be honest, the pediatricians are like the old school pediatricians, and they get like attached to the old technology without knowing that this can make like a very huge impact. It makes you like take better care of your patient faster, and the patient will be happier.
All right. Well, I thank you so much, Dr. Vermetten, for joining and sharing your insights. And again, thank you, Jerry, for putting together this panel. Or this.
Thank you very much. Thank you for having me.
All right. Thanks.
No, a really wonderful conversation, Rachel. Dr. Vermenten, really appreciate your time as well. I know how super busy you are in your day-to-day as well. So wonderful chat there with Rachel and Dr. Vermenten. And speaking of one great chat, we're going to go over to Stan now. He's going to talk with Bill Toronto, president of the Merck Global Health Innovation Fund and also the chair of the Breakthrough Alliance. Stan, over to you.
Okay, well, this is fantastic. We've got Bill Toronto, the president and CEO of the Merck Global Health Innovation Fund, with us now. And we're going to be talking today with Bill about some really important consequences and updates on what's happening with artificial intelligence and what it's doing in healthcare and life sciences. Bill, good to have you back on the Symposium. Thanks for joining us today.
Well, thank you. The shoe's on the other foot. Usually I'm the one interviewing, but I'm in the hot seat today, so look forward to the discussion.
That is correct. And again, you've got a tremendous history of working in healthcare and life sciences and put together some extraordinary companies with your fund. For some of the folks in the audience who've been living in caves over the last 20 years, maybe you could give a 1-minute overview about what you do at the fund and a little bit of your history.
Yeah, so I started the fund for Merck in 2010, so we're now in our 17th year, but we're a fund that's dedicated really to what we call pharma services. So we look at the pharmaceutical continuum from drug discovery, drug development through supply chain, manufacturing, IT, patient care, and real world evidence and data. And we try to make investments across those areas that are most important to not only my parent company, Merck, but also the industry. We're historically a growth equity fund, but we've moved into some earlier rounds, now A and B rounds. We still don't do startup or seed capital. We like to write checks between $5 and $20 million as sort of our sweet spot. Today, we have about 54 portfolio companies. And plus, we have some accelerator programs that adds another about 40 companies, so close to 100 companies that we're managing. So pretty good sized fund. And we're global investors. So we look at, not only in the US, but outside the US.
No, it's fantastic. And your horizon when you're investing in terms of getting returns is about 5 years, 6 years, or less year. Like how much you're looking for in terms of taking a growth company and moving it into some sort of an exit?
When we first started the fund, we were probably at the 3 to 5 year range. But I think one of the lessons you learn over time is, digital health and health technology and investing in healthcare is a long game, and it takes time to mature companies, scale companies, and do the things that you need to do to get the company where you want. So I'd say we're probably more the 5 to 7 range today than where we were maybe 10 years ago, which was a little closer to 3 to 5. And of course, the earlier you invest, an A and B round will take a little longer to mature versus the growth or C or D round company. But I would say on average, we're probably the 5 to 7 year now, but that's okay. It just takes time, to build companies. Some of the most successful companies we had, if you look at Preventive Solutions, which was our cardiovascular monitoring company, that took almost 11 years. Livongo, that was like 6 years. These do not happen overnight. They're big companies take time to build, and when you build them the correct way, then it really ultimately helps the patient in the right way, helps the community in the right way, and then of course me as an investor get to exit in the right way.
And clearly one of the biggest things in human history, much less healthcare and life sciences today, to affect healthcare and life sciences is artificial intelligence. We're seeing it every day have these mammoth impacts on what we're doing in across, whether it's patient diagnoses and looking at x-rays and MRIs and CT scans for things that humans have missed, or whether it's looking at a lot of the life science practices around early drug research, some of the development side of patient recruitment, and being able to submit data collection faster and do the data analysis in ways we could have never imagined. I'd love to get your take on which of the artificial intelligence technologies, and in generic, you don't have to mention names, are you seeing deliver the promise of what they've actually said they would deliver? Where do you think the promise is actually being achieved?
Yeah, so I think, as you mentioned, the one fascinating thing about AI in healthcare, it's affecting all aspects. Everything from what we see from a pharmaceutical industry, from drug development, clinical development, to how we do supply chain manufacturing, how we think about access, to patients. We're seeing a lot more AI use now in medication adherence, medication safety, care delivery, is AI, because the data is just more richer. We have more access to data. I would say we're still in the early stages of AI. It's not that AI hasn't delivered really good returns in certain areas, but I would say more in infrastructure so far. Things like supply chain and manufacturing, we're certainly seeing it work really well. I think certain areas of patient care delivery, we're seeing it work really well. I think things like drug discovery, it's still early yet. We don't have anything that's fully made it to market yet, but we're seeing drug get to phase 2, phase 3. I think in things like radiology and pathology, we've seen great strides because to your point, we're able to read scans that we weren't able to read before. But I think we have to manage our expectations because it's still very early yet, and I don't think we even come close to exploring all the areas and where AI can impact healthcare. But it's also only as good as the data that we have as well, and the better access to data, the richer the data, the better AI can work for us. But it's ultimately just a tool in the end. It doesn't have judgment, and that's where a lot of healthcare still resides. With a clinician, there's judgment involved. There's judgment across every aspect of it. So I think there's great hope. We're seeing lots of areas it working really well, but I think we just have to temper our expectations where we're just in the early stages. I remember I've had this talk before where when I started to fund in 2010, remote monitoring had just started. And today you can monitor everything. There's not a single thing you can't monitor. The devices are small. They collect so much data. We don't even think of monitoring that we can't monitor anymore, right? And so I think we go back to 2010, that's sort of where AI is. It's in its infancy, but it will expand and grow faster than monitoring is. So probably in the next 3 to 5 years, AI will probably take over a lot of portions of healthcare. But we're seeing it help in a lot of areas, especially on access, around delivery, around drug discovery, clinical development. There's just a lot of good areas that it's working well right now. But again, early stages.
Fantastic. And you've seen so many companies over your career, ones that have scaled, like the extraordinary, the record-breaking deal with Livongo, $18.2 billion exit to Teladoc. And then you've merged companies together in the past as well. And so what are some of the key elements of seeing companies scale and be so successful versus others that never quite make it? What are some of the elements, some of the variables that you see in your career that distinguish the highly effective, the high adopters versus the ones that can't quite get there?
But I think ultimately, in a simplistic form, is the company solving a problem or a use case that someone in the healthcare community, whether it's a hospital, a patient, a provider, anybody, any portion of the healthcare community wants that problem solved. And that's the first step. If it's a real need, if you're solving a true need or a true problem that really affects the community, then that's the first thing in helping something scale, because you're solving a problem that has to be solved. I think the second is making sure that you understand that most of these companies start as point solutions, right? And a point solution ultimately doesn't scale, and you have to think of more of an integrated solution. And so what you need to do as a company is you might have 50, 60% of the solution, but you don't have 100. Well, what pieces are you missing? What are your gaps? Then who are you going to partner with? I think one of the key aspects of the companies that do really, really well is they partner with a lot of other companies to fill their gaps. And they offer a more integrated solution that scales much more quickly. So if you see a lot of the companies that did well or have done well in healthcare, is they either have done a lot of M&A or they just have a lot of partnerships that don't necessarily require M&A that builds a broader solution that solves as close to 100% of the problem that you're trying to solve. And then making it simple for the end user, whether it's the patient, whether it's the provider, whether it's the pharmacy, whether it's the health plan, whether it's the pharmaceutical company. Is the solution easy enough to implement? And does it drive the efficiencies and the clinical pieces that you need? And that's the final piece I will say is, a lot of times in healthcare, a clinical outcome is the most important thing. And a lot of these solutions, especially if they're directed at the clinician or the patient, are they providing outcomes that are measurable? And again, if you're solving the right problem, collecting the right data and have the right tools against it and providing, the right outcome, then you're going to be successful. And the ones that don't, just they focus too much on a narrow piece of the problem. They're not thinking holistically about the larger problem that they're trying to solve. They haven't partnered well, or they just don't, not always the right tool wins or the best tool. It's how you build a community around the tool. I think that wins the best. And the ones that don't think that way and think more individually about their product or company tend not to scale or do well.
Last question, Bill. I know you're super busy, but as everyone knows, you're the chair of the Breakthrough Alliance, and which recently expanded into Asia with the phenomenal meeting at Merck in Seoul, South Korea last week. And clearly, like you just mentioned, the digital health ecosystem, healthcare AI now has gone global. So the best AI is not necessarily just in New York City or San Francisco. It's now also in London, Paris, Tel Aviv, Delhi, Singapore, Seoul. So now the question is, with these innovation centers growing and with life sciences needing to be able to get the best AI within their companies for research, for development, for commercialization, et cetera, how do you see the Breakthrough Alliance, North America, Europe, Asia, impacting these international partnerships that you're talking about and the development of the adoption of this movement of artificial intelligence in healthcare and life sciences?
I think it's an unbelievable community. The way I think about it is there's one Breakthrough Alliance, right? And we just happen to have spokes or hubs in North America. We have one in Asia Pacific, one in Europe, and they all work together. I think it's important if you really want to understand how the world works. So the interesting thing is, a healthcare patient in the US versus a healthcare patient in Asia, they're still a healthcare patient with the same issues and problems. What changes most cases in these areas is just the way things are reimbursed or paid for. But treatment is still treatment, care is still care. And trying to identify where the best technologies come to help patients the most, I think is the most important thing. And being part of these communities is the most important thing. And I think if you're part of the US contingent of the Breakthrough Alliance, get to the European event, get to the Asia Pacific event, and vice versa if you're one of those other communities. You've got to travel and learn and see what's out there in all these other communities. But being part of the community is the first step. You got to join, you got to participate, and you got to learn. I think that's how we can best serve the industry, is showcasing all the different entrepreneurs that we have, all the different people that are part of this, all the different facets of healthcare that are members of this, and learning from each other what all of our use cases are and the interesting things we're trying to solve for, and then what are the best technologies to help us. And you can look globally, but you got to be part of these communities, and this is a really good one, the Breakthrough Alliance.
Sounds good, Bill. As always, love the perspective that you bring to the ecosystem, and the ecosystem is greatly appreciative for all that you've done over the last 15 years here. You've really helped progress it by providing the perspective that a lot of folks don't quite understand of the manufacturer, but also of all the health plans and hospital systems you work with. So greatly appreciate your time today, and looking forward to speaking to you again next month here at the symposium. Take
Thank
care.
you very much. I appreciate it, Stan. Thanks for the interview today.
Really phenomenal conversation, Stan. Thanks so much for holding that with Bill. Everybody, I encourage everyone to connect with Bill to learn more about what he's doing at Merck and also the Breakthrough Alliance. And from one leader of our HITLAB initiatives and the Breakthrough Alliance to another, Divya Verma, who is now leading our Women's Health Tech Initiative, is now going to have a conversation with Niharika, who's leading AI and machine learning at United Health. Over to you, Divya.
Thank you so much, Jerry. Hi, Niharika. It is so nice to have you here. Niharika is the Associate Director, the lead of AI and machine learning in United Health Group. And today we're going to be focusing our conversation on AI and machine learning in the clinical setting. So Niharika, do you want to just give a quick background about yourself? We would love to hear more about you from you.
Yeah, hi everyone, and I'm so sorry for this mess setup. I'm shifting
No
my
worries.
place, so you have to deal with the background.
No worries.
And currently, I'm working with the machine learning. My experience has started with data science, and with machine learning now for 3 years, I've been working to AI modeling, and it's been almost a year working with the United Health Group. So my experience with healthcare is not phenomenal, but it's impactful, I would say. And
Absolutely.
that's how I would like to introduce myself.
No, thank you. Thanks, Niharika. You have a very important role to play, so just keep that in mind. So I wanted to ask you more about AI and machine learning. So one of the things we're curious about is how is AI and machine learning reshaping medication safety? Whether it's clinical decision support, to identifying and preventing adverse drug events.
Okay, so actually, I would like to give my own perspective about it, not with
Absolutely.
respect to the company and everything. My own perspective is when we see AI or when we see machine learning, we miss one important thing. We focus on, inventing new feature or what advancement that we can do, but we forget the fact that there are many things already done in the environment, in the ecosystem. How we can evaluate that, how we can, broaden the horizon for those features, that is the most important thing. So currently I am doing some research on how, the current economy or current ecosystem needs AI. And if you know, the recent situation is now we are not constrained to one country, one city, or one environment, or one hospital.
Yep.
So if a patient from California had few tests, they found out that, okay, just giving you a scenario how it happens right now.
Yep.
So he find out that, okay, he has chronic disease which has to be treated. Now, if he takes the treatment in US or any other country, he finds it very costly to get treated there. But most of the time they come to India or move to any other city where it is affordable or the healthcare system provides much more beneficial things about that. The biggest challenge is when test is done in one country or one hospital, the reports has to be transferred to the another hospital where the patient want to get treated. But that is the, loophole in the system, that everything has to be done manual right now. They have to bring the reports. For example, they took lab tests from LabCorp, they took lab tests from any other lab company, and they have the patient's tedious stars there. They gather the reports and bring it to the another hospital where everything upload, the hospital uploads the data manually. So this can be transferred using the AI system or machine learning system. So we are working on Fire-based system right now. Fire is the database which is centrally working for these things. That can be expanded to other countries also. Right now it is for US, mostly it is expanding in US horizon, but it can be expanded to other countries, which will make the life of a patient very easy to take medication from one city or one country and take a treatment from any other city, because they don't have to travel with a report. Everything will be fetched. That can be the enhancement in the drug industry also.
Yeah.
Right now the reports are being transferred, but the drugs that are prescribed to the patient in one hospital, that has to be transferred to another hospital, because traveling around with hundreds of paperwork is a tedious task for one person. And being honest, no one is that uh, peculiar about having all the paperwork stacked in their wardrobe. So that can be one big change that we can implement using AI. So there are many features like smart bottles are there to track whether the patient is taking the medication properly or not. So
Yeah.
all these things can be tracked, can
Yeah.
be transferred from one hospital to another hospital, and this will one somehow get the benefit of insurance claim. Because
Yeah.
right now the another problem that most of the people are facing are the insurance claims are rejected for whatsoever reason. So if you have all the data, if you have all the prescriptions in your hand, if you have the data with you,
Yeah.
nobody can deny the fact.
Yeah.
So this can be revolutionized using AI. So we have to focus on these existing systems, which can be changed rather than inventing new system or inventing new process, because everything is centralized now. If the data are centralized, then 80% of the problem is solved for a patient. And our biggest concern is, our biggest goal is to make the patient's life easier.
Yeah. No, very well said. And, thank you for that example, like to make it very real. And, I think that just like you mentioned, like with globalization and with, a company like United Health Group, I mean, who better than someone who is global, covering so many lives, to take such a task on. So I think that was really good perspective. And when we were talking, you also touched upon like smart bottles, right? So just digging a little bit deeper into that, what are some of the biggest opportunities for AI to improve pharmacy operations, medication adherence, right? And possibly personalized treatment recommendations, according to you?
So there are many apps that tracks the medication. If
Mhm.
you put the
Yep.
medication, everything is online now. So the OCR can extract your prescription, and based on the dosage, it can alert you with the, at what time the dosage has to happen,
Yeah.
which, food item you have to take before certain medication so that it can work properly. So all this medication can be tracked easily using AI or the application system. So if we have the data, if, as you said that, okay, smart bottle is there are many apps are there which can be utilized. So the patient is also, on an alert to take the medication on proper timing. And this can be, a very big benefit for that patient or for the health industry or for the insurance claimers, insurance companies, to have a exact phenomena of what is lacking with the patient or where the support is needed. Because if the patient is taking the medication properly, and this can be, again centralized, because if the medication is prescribed by a hospital or a clinic, and these medications are being directly given to the medical centers or pharmacies, so these all things can be centralized, which kind of drugs. Secondly, this can be, error correction, we call it, like bribery correction, what we call. So sometimes what happens, the clinic prescribes some medicine, but the clinic, the pharmacy are already having some deal with some company, some pharmaceutical company. So they would suggest, okay, this medicine is not with us, but with the similar prescription, similar chemicals, we have another brand that might be a little costlier, but we have another brand. So with this process, you can track whether, some drugs are being promoted by the pharmacy, or, is it a proper amount or proper doses that a patient is getting or not. So all these things can be tracked, all these things can be put to an advancement. And right now I don't think it is up to that level that people are using all these things. But if promoted properly, if promoted by the clinic, EMRs, or the pharmacies, it can be a very good revolution to health industry.
Yeah, no, completely agree. I think there's a lot more to be done, but we're definitely in the right direction. So as healthcare organizations, adopt AI at scale, how do you think they can ensure transparency, fairness, and trust while maintaining patient privacy and regulatory compliance? I mean, we're talking about patient data, right? So if you can just share a little bit about that as well.
Actually, one thing, with my personal experience, recently my father was admitted. So I faced this issue.
Yeah.
That most of the time doctors, either out of sentiments or humanitarian ground, they don't reveal the entire thing, or they might think that, okay, they are patients' family, so they might not understand the clinical terms. So they don't tell things very transparently. And at the end, during the time of billing, when we are in a hospital, even a moral value comes into the picture, that we can't ask for what kind of drugs you prescribed, what kind of procedures you did, because we have to trust the doctor completely. That's where this blank space happened, that transparency is not there. We have to rely completely on the hospital. We have to completely trust the hospital, whatever they are prescribing, whatever charges they are giving. So again, as I mentioned, that there is a database, central database. If we can expand that database based on not only the medical history or transferable, interoperability, but also the charges, what kind of, because I have seen it charges differ from one hospital to another hospital, like rapidly, for the same procedure, for the same medicine, for the same treatment. It can be from, saying in US terms, like $20 to $200. So there should be a capping from a government, or there should be capping from central authority for each of the operations or each of the treatments. That can be really beneficial for the patient, because at the end we are people for the patients. And that will again go to the main ecosystem of the insurance claim process also. And coming back to actually one question, I think the speaker before me was mentioning that for drug discovery, we don't have much discovery right now. So I'm doing my master's in quantum computing, and we are working on drug discovery because quantum is working on protein analysis, which can be like after 2 years. We have an estimation of 2 years. After 2 years, it will be like a full-fledged application, a full-fledged research project, how drug discovery can be done, and what kind of amino acids can be extracted from a single protein. So that can be a revolutionary after 2 years, when the quantum computers are in a very working condition. Right now we have just discovered, like few company has discovered 34 qubits, few companies have discovered 39 qubits. So once it reaches to a level, drug discovery will be the biggest thing for the century, I would believe.
Yeah, no, absolutely. And thank you so much, Niharika. With that, we're going to have to wrap up this session, but it was a pleasure speaking with you. Good luck with
Same.
your master's as well. And we're really looking forward to, United Health Group and yourself expanding the role of AI in healthcare.
Thank you so much. It was a pleasure. Thank you.
Same here. Thank you.
No, that's brilliant, Divya. Thanks so much for that important conversation with Niharika from United Health Group. Really, really timely and really, really insightful for the audience today, I think. I encourage everyone to, of course, connect with Niharika and, of course, Divya as well to find out more about what they're doing. Next up, we have a conversation with one of our HITLAB startups again, AcuCardia. You may have heard of them, and Stan is now going to have a conversation with Dr. Naveed Razvi from AcuCardia.
Fantastic, Jerry. Thank you very much. And I'm really interested in what's going on with AcuCardia. As Jerry mentioned, this is a HITLAB validated platform and making massive inroads with taking data that previously had not been touched by AI and now really making it much more impactful by using their platform to interrogate it. But let's start off and talk a little bit about you first. The audience would love to meet you a little bit and get to know your background. If you could give us a 1-minute background and profile on yourself.
Yeah, sure. Hey, Stan, thank you. Can you hear me okay?
Loud and clear.
Yep. Hey, excellent. Yeah, my name is Nav Razvi. I'm the Chief Medical Officer of AcuCardia. I'm a practicing cardiologist in England, and I've been the Chief Medical Officer for AcuCardia since startup for about 10 years. So we've worked with HITLAB on projects in the past and collaborated with some of your symposiums as well. So this is my first one. So it's exciting to be here. It's great to meet you again and talk about pharmacy and AI and cardiology as well.
It's wonderful. And tell us a little bit about, again, another minute or so about the platform itself and how it's really breaking through in areas that we never would have imagined 3 years ago.
Yeah, sure. So AcuCardia is an ECG company. It's agnostic in terms of devices. So as opposed to other people you might have heard of who do hardware or who do ECG signals on a device, we are software. So we can take any kind of ECG signal into our engine, and then it provides an analysis and readout. So we have FDA-approved products currently in the market for remote patient monitoring via Holter or MCT. So this is our kind of regular product. So this can ingest ECG data from anywhere and give you an analysis. So that's a kind of main consumer kind of product. But we also have a lot of AI-driven novel use case products out there. So this takes ECG reads and can give you a signal prediction for things like aortic stenosis or hyperkalemia. So these are our two big research products at the moment where we've presented in meetings. We got meetings in the European Society of Cardiology coming up where we're presenting some of our latest data, as well as the AHA last year. So that's all out there on the internet if you wanted to look up that stuff. and we've done previous work on QT as well with HITLAB. So that's more useful for in this domain for just kind of drug monitoring and side effects, and we'll touch on that later in the questions.
Yeah, let's dive into that again. I think talk a little bit about how the AcuCardia platform is improving drug safety, medication management, and overall accessibility and outcomes for patients.
So the AcuCardia platform records the ECG signals and gives you an output around the ECG and monitoring. For things like drug safety and things, we're touching on AI. What the AcuCardia platform will be very good at is ingesting all manner of data. So with all the proliferation of wearable tech out there, so you've got your watches and you've got your rings and you've got sensors in many things. So you've got so much different data now in the community. And the paradigm of healthcare has changed, whereas before you might get data episodically from a consult or from a hospital visit. Now there is data being generated almost continuously in every setting. So patients at home, people at home are getting data. And what do you do with that data? So your regular clinician is going to be inundated with that and overwhelmed. So things like our platform can ingest that data and give you a meaningful output. So we can ingest a range of ECG at any duration and give you a summarized breakdown of what that means and make it clinically useful to advance patient care.
That's absolutely amazing. And I think that's where we're seeing AI make the biggest difference. And obviously the HITLAB validation study that we did on AcuCardia showed just how high the efficacy was. So we've got about a minute or two left. If you could talk to the audience about where the future of this is going. What is the future of AI going to look like for what AcuCardia is doing, and where is the future of the impact of AcuCardia going to go?
Well, that's a huge question, isn't it? So, well, the future is exciting. The future is broad. It's making all of this data useful. So, if we take it into a more kind of clinical perspective. So, as a cardiologist, if we look at the main big kind of cardiovascular diseases with a bigger kind of pharmacy or medication oversight, where you've got hypertension, you've got heart failure, you've got atrial fibrillation, and AI now can bring all of that into focus. So some of the technology or some of the things that we can do, so we can screen electronic health records, so we can go looking for disease where it was hidden before. So we've got arrangements where you can screen a tranche of data, so data embedded in the health records, historical data, and pick up ECG diagnoses where it was missed by perhaps individual clinicians or individual operators. So disease findings, so things like AF, atrial fibrillation, that provides a health benefit. So if you find these patients and treat them, then you're avoiding the downstream risk of strokes and heart failure and earlier mortality. So that's one of the things that we can already do in AcuCardia. Other diseases, so if we're coming back into the AI spectrum and a little bit away from perhaps what we do directly, but look at all the other sensors out there. So what you want your AI to do is to make it clinically usable. So you've got lots of different data, you've got lots of different devices, but something to integrate that. So things like heart failure, where one device might see a change in weight, another one might see a change in heart rate. You might see a change in your patient's activity with the number of steps they're taking. And all of that adds up to perhaps deterioration or the patient falling off from their heart failure control. So your AI could signal process all of that together and give you an alert sooner than the patient pitching up in hospital in a worse off state. So all of this is exciting for the future, bringing these technologies together in one space to make it helpful and useful for the patient, to protect them from being in hospital, to catch the disease earlier or catch disease where it was missed before. So there's some kind of examples in broader AI and how we want to use that. But in AcuCardia ourselves, so some of the things that we've done, so like our aortic stenosis model, we've got the ECG as a screening tool. So now we can pick up or have a propensity score for aortic stenosis from the ECG. So in communities where you do not have access to things like echo, or there's half the counties in the US do not have a cardiologist. So your ECG signal can give you a risk of aortic stenosis, to then triage your patients to find the guys who might need treatment before things get too bad or before you see that mortality creep in.
That's wonderful. Well, again, greatly appreciate the tremendous work that you and your teammates are doing with AccuCardia. Again, anyone who is interested in working with AccuCardia, take a look at the chat. You'll see their LinkedIn there, and certainly contact them directly. Thanks again for joining us today.
Thank you, Stan. It's good to be there.
That is wonderful. And we're excited to bring you more evidence of digital health adoption, AI adoption in healthcare life sciences, particularly this month's edition in pharmacy and management, and AI and digital and pharmacy management. And we're very lucky to have with us today someone from the Veterans Administration who is one of the leaders there in doing this. And he's going to give a presentation on what they're doing and how they're affecting change. And so with that, I'm going to hand it over to Brian to do that. Nice to see you, Brian. Thanks for joining us today.
Hello, everyone. Thank you. Thank you. Can you all hear me okay?
Loud and clear. Yep.
Perfect. So I'm going to go ahead and try to share my screen. Let's see. Okay. Now, please let me know if there's any issues.
Yep. Looks like it's sharing now.
Let me try to go.
Yep. Your screen is sharing.
Perfect. And do you see the presenter mode or the actual
Yep.
slide?
You're in presentation mode. That's correct.
Okay. So let me swap presenter mode. How about now? Just the slides?
Perfect. Just the slides.
Awesome. Thank you very much. Again, thank you for having me. I know you guys have probably got some presentation fatigue, but I'll try to be efficient with the discussion. And for me, and what I hope to do is really kind of talk about the broad spectrum of AI within clinical pharmacy. So my role within a VA, Veterans Healthcare System, is a clinical psychopharmacologist, right? So I'll be discussing from a standpoint of more clinical pharmacy and some of the potential integrations of AI. I won't be too detailed with what the VA specific elements are within AI, but
hey, Brian, a quick note: we can actually see your speaker slide. So I think whatever you had the first time is actually the presentation mode.
Okay, so let me. How about now? What do you see the full slide on its own?
Yep, this is the right mode. There you go.
Perfect. Okay. All right. So I'll go ahead and jump right into it. Just from disclosure's perspective, no relevant financial relationship. All the discussions here related to medication technology, AI applications. It's just for educational purposes. It's not in any affiliation with the VA, and we will be using patient cases to more so be illustrative of the discussion, but they will be de-identified. So hopefully for today, I want everyone to be able to recognize some of the practical ways AI can support clinical pharmacy. I'm sure some of the discussion has focused on some of the automation and pharmacy, sort of the day-to-day field prescription. I want to look at more of the clinical side of things, and this can apply to any type of provider, not limited to just pharmacists. But I want to be able to hopefully evaluate some of the risk, biases, some of the privacy concerns, and potential model drift that we may see. But ultimately, I hope to be able to apply this in a more human-centered framework where we can see where AI can be integrative in a safe way and some potential uses in the future. So I want to start with a case. Let's introduce Marcus, right? So this is a 52-year-old male individual with bipolar disorder, also type 2 diabetes. They've been stable for several months. Now, just a reminder, this is not an actual patient. But their current care, they include lithium, quetiapine, and metformin. It's your medication regimen. We do see some early changes that want to pay attention to. They've been sleeping less, some missed doses, and a few refills that has been late. As far as their engagement, they missed one appointment, but they have been less responsive. So this kind of brings up an opportunity, right? Where can AI assist pharmacists or any provider in this case? Just for you to reflect on, what kind of data could be connected, some signals we could look at, what are some risks that could be noticed sooner, what tasks we make easier, just in general. So we're looking at this case from the perspective of what a provider may encounter, right? And traditionally, this is before we start even talking about AI, there's just a lot of different things we could think about. But we will come back to Marcus a bit later. For now, let's kind of delve a bit into the AI trend over the years. So it's been, as you noticed, moving from more experimentation to routine practice. We can look at this figure here. It was just a survey from AMA. Between 2023 to now, there's been a growth up to from 40% to about 80%, right? So we're talking about double, and the trend will continue to rise, all right? So some of the changes that we're seeing, about 2.3 average AI use per case per physician in 2026. We're seeing upwards of 30%, 39% of AI use for discharge instructions, care plans, progress notes. And then just perspective-wise, about 70%, 76% and above believe AI can improve the ability to care for patients. So there's optimism behind the use of AI, and the adaptation of AI within clinical care is expanding. So we can't ignore it. I mean, hence this discussion we're all having here today, the symposium. AI is a critical component that we can't sort of just assume will disappear. It is being integrated, and the literature will suggest that there is certainly a lot of discussion about it and perspective on, should we use this? All right. So some more figures here to discuss. Medication management, when we look at the potential cost, we're just zooming out. There's a 42 billion annual global cost of medication errors, right? So this just brings about a potential discussion on where AI can intervene with economic implications. We're looking at about 50% harm linked to medications alone. Data generation does not stop. But we all still have the same goal. We want to prioritize the right patient. We're looking at the right risk, the right intervention, the right time. So this isn't simply saying AI is, going to overtake healthcare. This more so presents the case that there's more technology, right? We have more information with what patient care looks like, right? So exposing more information, what do we do with this information? How do we organize it, right? So medication management in of itself, it can produce clinically relevant signals, but we still need the provider, the pharmacist, to step in to determine what do we do with this information that is now organized. Now, we can look at AI as more so of a capacity multiplier. It's not going to substitute judgment for us. So looking at what AI is strong at, recognizing patterns, rapid synthesis, workflows that are repetitive, prediction from structured data, right? We can at least say there's some benefit there through experience, through data. But what about pharmacists? We're essential for more of the clinical context, right? We've gone through all this training to identify risk-benefit judgment, right? Experiences will help us to determine when do we step in beyond the guidelines, right? We develop patient trust. Pharmacists has always been noted to be one of the most trusted healthcare providers. We're very patient facing. We also have ethical accountability, which applies to all providers in the healthcare system in general. But overall, we hope to make better medication decisions. Looking at some places that AI can potentially move clinical pharmacy from being reactive to proactive. So medication safety, that's an easy one. We looked at some of the numbers related to the cost associated with medication errors. Clinical decision support, predictive analytics, workflow optimization. We'll see that when we talk a bit deeper into some of the positives, and personalized care. Now, there's still a lot of red tape that we have to be careful about. Pharmacogenomics is actually more of an emerging element to healthcare and pharmacy practice. So incorporating AI there, again, we want to more so look at it as organized information versus determining the clinical next steps. So let's go through some of the good pieces of AI, right? Where it's currently creating value, and I'll talk a little bit about how I'm actually using it within my setting. But the goals were better triage, faster synthesis, more proactive care, and more time for the pharmacist to interact with patients. The big thing that we often deal with is alert fatigue. And the issue with alert fatigue, when we look at traditional care, it can often lead to frequent overrides, like just kind of, okay, this is too much. Let me just kind of skim through this. High volume burnout can come from that. And you're trying to find a way to organize this. So AI augmented care can provide a little bit more specific patient risk analysis, some of the severity, likelihood, accountability, creating more of a dynamic context, right? Pulling data together. But the pharmacist still has to review, right? Verify, counsel, adjust, and document. These are things we're doing already, but with the assistance of AI, we're better able to be efficient with what we normally do. But overall, we still want to have measured outcome as a priority, and pulling the information that AI provided and using our background, we're able to look at the ADEs more appropriately, efficiently, overrides that aren't fatigue based, acceptance of what is necessary, and being able to look at things more equitably. As far as a medication recon, it's a big part of pharmacy practice. Every pharmacist knows that if you don't have this down pat, you can miss a key piece of a patient care. But it's also associated with a lot of fatigue. So AI can certainly support in this area as a room where AI can sort of integrate itself within our care. But normalizing medication names, comparing multiple visits, this is something where with fatigue, we can experience errors. But with AI, at least there's some automated process. Of course, there still needs to be a pharmacy input or a provider of any background to determine the intent, the relevance of the information provided and consolidated, any discrepancies, and be able to communicate change to the patient. Overall, we want to be able to have fewer documented discrepancies, faster prioritization, easier and more clear handoffs, and more time for what we are trained to do. Again, pharmacists, we want to look at our role in any provider, really, in the clinical setting as a translator between the evidence that we already have and patient. So one of the key things that I tend to use AI tools here at the VA for looking at some trials, right? Pulling information, data. What does the latest guidelines say about treating a patient with bipolar disorder or schizoaffective disorder with this potential background? All right. Now, patient goals, patient data is still must align, but this is more so pulling data that we can use. Again, saves time. And the goal is to provide the clinical pharmacist or the provider just patient-specific recommendations. Specifically here at the VA, and this has actually been a newer implementation, there has been guidelines and the slow transition, which is more in the pilot phase right now, but AI tools that are accommodated for the federal government system. All right, so as you know, there's a lot of safety guards. Cloud for Government, for example, there's a huge guideline that we must be able to review and take heed to. And as we're using Cloud for Government, they're collecting data, collecting information, determining whether the use is appropriate, if there's any breaches, how is that managed? And I've used it a few times, mainly with these sample cases here, documentation, clinical information, summarization of some of patient records, analysis of data, process of support, communications, which is more limited there because again, you want to have a lot of more of the human interaction when we're communicating either to another provider or to another patient. But training and education, I've developed tools within the Cloud for Government system, which allowed me to kind of save time, right? We do a lot of education to other providers, to patients, create documents with this tool. Economic value is always a big element of why we're even incorporating this, but not to harp too much on this. We talked a bit about it, but avoiding adverse effects, reducing readmissions, we know the cost associated with that, which continues to rise. Administrative efficiency and an expanded panel search. Let's go back to Marcus. Now let's look at a case or an incident here where AI is used for good, or it feels like it's good. This is where AI can combine what the team may see separately, right? So we have a bunch of information. I have oftentimes I'm typing my notes. It's layered in within an electronic health record system. I have to manually review the patients and their information to determine, all right, you missed this appointment this time, you're getting this hours of sleep, but it's not consolidated, it's not trended. So what AI can do, some of the benefits here is combining that information together and providing a consolidated report. So identifying signals, and you can see here for our good friend, our good patient here, Mr. Marcus, sleep is not too good. They missed a few visits according to the information AI was able to pull. Recognize that, hey, we missed some labs for metabolic monitoring with the quetiapine the patient's on. 5 missed doses since the last visit, something to pay attention to, and so forth. So the output is telling us that there's multiple signals that need attention, and we may need some further warranted review because it can impact patient outcome, right? So it didn't make a decision for us. What it did is reduce that work list. It provided the information that we've already compiled in an organized manner and alerted us to determine what to focus on. Again,
that's great. We've got about a minute left, Brian, just so you know.
All right. So to kind of focus a little bit more on what that can do for patients and then pharmacists, verify, we can contact, we can coordinate and monitor overall for the care because of the information that we receive from the AI. Now to kind of look just for the purpose of time, just want to touch on what providers bias may have occur when we're looking at AI. Confirmation bias. Do we always assume that AI is correct? Are we dismissing our own knowledge and the clinical judgment that we have? So it's important to mitigate these information. And of course, equity concerns. We know that AI does not automatically account for subgroups. So if we're not paying attention to that, we may miss how it can impact our patient. So with Marcus here, if the AI model is not looking at some of the individual patient parameters, it can miss critical information, and that can lead to incomplete information, risk, and automation bias, which tells us that the patient is okay when they actually are getting worse.
Right. We have to jump, but appreciate the all the detailed data here, Brian. This is phenomenal. And again, we've got plenty of people that have questions. They'll be contacting you on LinkedIn as well.
Okay. So I'll just go to my information here at the end so that you can reach me right here. So admin at My Mental Keys or LinkedIn. Thank you very much.
Very good. Thank you. And lots of emoji thank yous coming up as well. Really appreciate your time today, Brian.
Thank you.
And next up, we've got even more folks talking about what's going on within AI and digital in pharmacy today. And clearly, when we talk about this, we're talking a lot about what's happening within innovation in gene therapy. And we're seeing incredible leaps and bounds of progress there. You've seen the acquisitions over the last year in this area. And so that's always a good signal about what's heating up there as well. And with us today is Neha from Bausch Health, and handing it over to Neha. Neha, it's all yours.
Thank you. Thank you, Stan. Hello. Can you all see me? Yeah.
Yep, you're coming in loud and clear. You're good.
Okay. All right. So today I'm going to moderate this session, and we have a couple of really interesting questions for Iman, who will be joining us from Bristol Myers Squibb. Do we have Iman online?
Yes. Hi.
Yes. Hello. Hi.
How are you?
I am doing well, and today we are really interested in learning more about CAR T cell manufacturing and your point of view, as well as what you've been seeing and how AI and data science has been helping the manufacturing processes in something as precise as CAR T therapies. So, how have you seen digital technologies and automation improve the manufacturing efficiency for CAR T therapies while also ensuring quality and patient safety?
Yes. So, um, hi everybody. Are you able to see me, by the way?
Yes, yes, I can.
Okay. All right, perfect. All right, so good afternoon, everybody. My name is Iman Azim. I'm 23 years old, and I've started working as a CAR T manufacturing operator at BMS since January 2026. So a little bit about CAR T manufacturing is that our responsibility at BMS is that we receive immunocompromised cells from patients around the world, from different parts of the world, and we bring them into our facility where we basically where we harvest their T cells, their blood cells, from their blood samples, and then we wash those cells and then we preserve them, and then later on we inject a material to basically help fight off the cancer within their cells. And then we basically do autologous cell expansion, where basically we grow and create multiple copies of those genetically engineered cells. And then we send those cells back to the warehouse, and then they get infused in with the patients who are currently suffering through different types of blood cancers, specifically leukemia. So this type of CAR T therapy is very recent, actually. They've started doing this since, I believe, 2021, I'm certain, the facility that I work at. And a lot has been changing since I've actually started, and even today, things have changed dramatically. You spoke about AI and automation. From my understanding and from the 6 months I've been there, I've seen a lot of automation happening, specifically when it comes to maintaining the quality of the product. Recently, we are in partnership with Claude, with Anthropic. They basically allowed us to deploy Claude tools, to use them to help us understand any sort of deviations or errors that happen in manufacturing. Because in the beginning, what used to happen was that in manufacturing, we used to have operators, do all of the expansions by hand, use different types of machinery and equipment to calibrate, to make sure the parameters are matching and everything. And then we would have to do the processing for it. But with that, there's a lot of human error that happens. Sometimes the data isn't clear. Sometimes there are some disparities and some inaccuracies in the data. So we recently used Claude to kind of maintain that quality of product, basically. So we use Claude to make sure that the any deviations are happening, we can able to expedite the root cause investigations to make sure no errors are happening in manufacturing. We've also acquired different types of novel platforms and programs, such as recently we required NextX program, where basically it's used to calibrate and automate bioreactors. So rather than human beings actually dealing with such sensitive material, we use bioreactors actually to kind of equalize the process and streamline it for efficiency, so there's little to no error. And because of these initiatives, I have personally witnessed that our rate of error, our human error, our deviation error, has significantly decreased from 5% to 1.2%. So I believe, from my perspective, from my experience, I think automation happening in the manufacturing process has been incredibly helpful for us operators, because it allows us to not repeat our old mistakes. I'm so sorry, I apologize. Not allow us to repeat our mistakes, and it allows us to actually further expedite the process.
That sounds really great. And as you've seen this process evolve and all the help that you've been getting through your new partnership with Anthropic, as well as how you've seen actually AI provide impactable results, do you think what are the existing operational logistical challenges that are still present that could be potential use cases in the future that you see in delivering CAR T treatments from manufacturing to patients?
So, some potential challenges that I do see with CAR T manufacturing, to be honestly speaking, is that we are currently right now hyperscaling our operation, especially with one of our products right now. One of our CAR T products is exponentially taking off on the market, and so we're trying to upscale our production for that. However, there are some logistical challenges when it comes to it. When it comes to either finding the right equipment, finding the right type of platform to use that can efficiently, make sure that the chain of identity is being streamlined throughout the process. And there's also that era of having enough balancing automation and AI with human power. So I feel like that's a logistical challenge that we as a company and even my senior directorship, we are trying to get a hold of, is to understand how can we hyperscale our operation? How can we upscale it to meet this increasing market demand while also maintaining our quality of products? And so some initiatives that my company, BMS, will most likely be launching is we're trying to find new and novel platforms to kind of streamline a lot of the other departments, such as quality control, making sure that our investigations are more streamlined. We're also trying to make sure that our equipment that we're using is more automated equipment. So we are spending less time we're able to synthesize more patient material and create more cell culture material in half the time. Because currently right now in our lab, it takes an hour and a half to manufacture a cell batch property, but we are trying to cut that time in half so we can mass produce more. However, there might be some challenges, especially when it comes to human error. That's another thing that we need to be very, very cautious of, because if there is a slight misstep in the data, a slight misstep while calibrating the systems or creating the cell culture, or a little bit of a mistake in whether it comes to gene editing for the injecting the genetic material into the cells, it could cause great harm to the patients. So maintaining that quality over a large scale of time is very, very important.
And as we talk about like how crucial it would be to maintain quality and maintain like consistency across
Yes.
everything as you hyperscale
Yeah.
your operations,
Mhm.
how do you think digital traceability and sort of like how does regulatory figure out into all of these processes? Because these are like really critical processes where
They
we
are
are
very
now trying
critical.
to, yeah. So
Yeah.
yeah.
So regulatory, our main thing is our main like aspect of making sure that we are maintaining that quality, especially through regulatory, is creating something called a chain of identity. So our chain of identity is this technological process where we maintain this like making sure that we are correctly identifying the lot, because we receive I have to say over 500 different types of lots from different patients all over the world. So making sure that they are being transported from the warehouse, from the different facilities and different hospitals to our facility to be manufactured in other facilities across the country and even around the world, because BMS has multiple facilities for manufacturing across the country and in the world. We have to follow this technologically advanced platform where it's called chain of link of identity to make sure that every single lot or batch that is being examined, sampled, or tested, and even being manufactured is matching the chain of identity that was created from the beginning. So even currently right now where I'm working, we have this process of making sure of checking and scanning the chain of identity every single step of the process to make sure that the quality is being maintained, and also we're not causing any logistical errors in the when it comes to manufacturing. And our regulatory department has been really, really on top of it regarding to making sure that our chain of identity is not being broken at all. And we're making sure that we're also, sometimes there are glitches in the system, and technologically speaking, there have been challenges to maintaining that because we have multiple different types of chain of identity. But our regulatory team has been really on top of making sure of streamlining this technology and making this more and more efficient. So we're not breaking that command of chain at all at any point of time. And we're also making sure that the right cell sample batch is being taken to the right patient.
That is very informative. Yeah.
Yes.
And finally, I think like this question sort of covers our entire conversation a little bit,
Yeah.
but this is more around like what do you think like going forward? What innovations in digital manufacturing, in AI, smart healthcare, logistics, do you think would have the greatest impact on scaling, as you talked about hyperscaling, something as precise as CAR T cell manufacturing? And while we also obviously maintain the safety and quality of these products.
Absolutely. So I think the most important part is if we're going to be using AI within our manufacturing operations, we need to streamline the different types of aspects of manufacturing, not just manufacturing specifically, but in terms of quality control and quality assurance. Because what typically happens is if there's a deviation that occurs, if a mistake happens, an error occurs by a human operator, we have to launch an investigation into it. We have to do a whole root cause investigation, and we have to examine each and every single part of the process to make sure that what exactly has happened for this error to occur. And then we create something called a kappa, which is basically a process of mitigating that mistake and then implementing that sequence that quality control has created to making sure that that event doesn't occur again. But all of this takes a great deal amount of time. It takes months to 3 months to 4 months, depending on how severe the error is. And sometimes what happens when we have these investigations is a lot of the process has to either stop or there has to be a severe audit regarding the process. So for that, I'd have to say is that we need to find a way, especially and I believe this is why we partnered with Anthropic to deploy Claude tools, is to actually minimize the amount of time it takes to do these investigations so we can get to the root cause quicker and faster and more efficiently. That way it doesn't hinder our manufacturing process at all. That way it doesn't delay us. Because while we're upper scaling, there is this constant fear, I guess you could say, that senior management at the company have been talking about, that I've been discussing with my colleagues, is how will we hyperscale with also limiting and decreasing our margin of error. And I think the best way to do that is through the automation of AI, in terms of making sure that our investigations are being written up properly, in terms of that our batch records are being thoroughly reviewed, but also very, very efficiently. And I think AI can really, really help with that, with the right prompts, with the right tools. We can able to streamline and efficient and make that process more efficiently. That way, so when the error arises, we're able to quickly solve it, quickly fix it, create the kappa protocol for it, and then quickly implement it, and then quickly also then find the solution and make sure that pattern doesn't repeat again. And I think AI will be really helpful in maintaining that data and creating those results. That way we're not able to repeat those patterns over and over again, and we can mitigate them before they arise again. I think that would really significantly help us, the manufacturing department, is because it would allow us to streamline that part of the process while minimizing our error and allow us to upscale our operation.
Fantastic. Well, this has been incredibly insightful and extremely educational. Really appreciate the interview, and looking forward to hearing from you both again soon. I think we're going to have a lot to talk about in this area as we're seeing the innovations jump by leaps and bounds. Thank you both.
Yes, thank you so much.
And what a terrific session. And I think when we start looking at digital and we start looking at AI in healthcare, life sciences, medication, et cetera, we know that this idea around where these sorts of cell and gene therapies are going to revolutionize what we're doing, and how digital and AI are driving those revolutions and those innovations. So great to see. And next up, we are very excited to have a conversation about something that is driving a lot of discussion in pharmaceuticals, which is this idea based upon the Supreme Court's ruling, and our expert Craig can talk to you a little bit more about that in a minute, around AI and patents and trademarks. And the Supreme Court saying that if you try to patent music or trademark music using AI, they're not going to permit it. And so that's a big deal for a lot of reasons. And we're going to talk about that now, again, with an expert in the world of patents and trademarks. Handing it back over to Neha.
Hello. Hi. So now for our next session, we have Craig Keniski, a partner from Brown Rudnick, and we are going to talk a little bit more about patents and the legal and regulatory standpoints when we deal with something like drug discovery using AI. And Dan, has Craig joined the call?
I'm here. Thank you for having me. And I promise I'm much nicer than I look in my headshot.
I'm very sure of that. Okay. So, Craig, let's get started with our first question. As we progress every day with getting closer to drug discovery and potentially like actually having something in the pipeline for an AI generated pharmaceutical discovery. What do you think? How would the patent protection for something like this would work? What level of human involvement would be necessary?
This is a more dangerous question than it sounds because people just have this attitude that AI improves everything in our lives, and in many cases it may, but we're dealing with 200-year-old laws that did not contemplate an AI world, and the laws haven't caught up yet. So it really depends on what we mean by an AI-generated discovery. So first and foremost, the current state of the law, for better or worse, requires a human inventor for something to qualify for patent protection. So the question is, how did the AI generate something? Let's say the human scientist tells AI, go search for all drugs that are known to participate in this pathway associated with diabetes. Fine, that's just searching for literature. Let's say the scientist tells AI, I have this huge data set that I don't want to deconvolute. Analyze the data and tell me what molecule is working best in this pathway. Fine, that's just data reduction. Nothing wrong with that. Let's say the scientist tells AI, design a novel chemical structure that you think will bind this receptor. That molecule, when AI spits it out, is not going to be something that was conceived in the human mind. That will not qualify for patent protection. And there's an epidemic out there of lawyers in my position not telling people this. And it angers me a little bit because we're supposed to be the people protecting the scientists from the law. And that would be a situation where no, that molecule wouldn't be eligible for patent protection under the current law.
And what do you think in the situation due to this particular legal gap? What do you think if something like this happens? How should an inventor go about it? And if an AI system, say, identifies a novel drug candidate, how would a lawyer deal with that? Like, who would be considered the inventor, the human, the AI developer, the organization, and what do you think how the law should deal with such gaps?
So under the current state of the law, an inventor can only be a human being, and a patent must have at least one inventor. And the inventor is a person who is the first to mentally conceive and envision the product or technology that is described in the claims of the patent. So that determines who the inventor is. To be eligible for a patent, there has to be a human being who did that. An institution, a company, a university cannot be an inventor. It has to be a human. So what the company needs to do, the institution needs to do, is first have policies in place, pointing their researchers in the correct direction so they don't give AI instructions that will lead to an illegal path. Fortunately, AI tends to do what we ask it to. So if we don't tell AI, hey, design a novel chemical structure, it probably won't. So that's a pilot error from someone who hasn't been properly educated by people like me who are supposed to be there to point them in the right direction. But here's where this goes bad. If you've ever filed a patent application, at some point, the attorney who prepared it for you sent you a document to sign. That document was called a declaration. This is a document that swears under penalty of perjury to the USPTO that I am the person who thought of the ideas that are described in the claims of this patent application. If you sign that paper, but AI thought of the ideas, then you have just committed perjury. You have committed a felony punishable by 2 years in prison and a $10,000 fine. Has anyone ever been indicted for perjury in a patent application? I don't know. It probably hasn't, but there's a bigger issue too. You go into due diligence with an investor. A good IP attorney in that due diligence is going to ask you the omnibus question. Is there anything else we need to know about this IP before we move forward? In response to that question, you're legally obligated to say, yes, I'm indictable for perjury for falsifying records to the USPTO. But no one's going to say that. What are the consequences of that? Well, If it ever comes out, if the investor ever finds out, they will be in a position to sue the company for recovery of the investment for misrepresentations in due diligence. The only way to win is to know the rules and follow them.
And so what do you think, like looking ahead, as you see more and more companies are using third-party AI models or using some sort of AI application, either to assist or in any sort of capacity, and which is now flowing into drug discovery as well. Going forward, what legal or policy changes will be most important to encourage such sort of AI innovation in drug development, while also making sure that there is a human involved and intellectual property is preserved?
Well, first, institutions and companies need to make sure they have policies in place so the scientists are doing things the right way and not creating problems that people like me haven't educated them on, because it's not their fault. It's the fault of the people like me who know the rules and aren't passing them on to the people who need to know the rules. And that's really what incenses me. What companies really need to do is keep track of how AI is being used. Data deconvolution, searching, docking molecules into receptors, go for it. It's the wholesale creation of a new idea that a human being did not put forward is where there's an issue. And we solve that by not asking AI to do that. Now, there is something you can do to mitigate. And this is a solution to so many problems in IP that I push on people all the time. If you're going to do something or want to do something that you think might be a little bit dangerous, before you do it, file a provisional patent application on all your ideas. If you want AI to screen for what molecule you think would be best at binding this receptor associated with diabetes, do a literature search, find all 400 molecules that hit this pathway, file a provisional patent with all 400 molecules in it saying that you think that they're good for treating diabetes. You don't have to be able to prove it to file a provisional patent application. You just have to be able to explain it a little bit. The patent office will whack you $300 to file that provisional patent application. And once you file it, you've got proof that you had this idea before AI did anything for you. Government records proving that you thought of it before the computer did are the best protection you could ever have.
Makes a lot of sense. Yeah. Okay. Anything else from your point of view? What inventors and what should pharmaceutical companies in general and drug discovery biotechs should keep in mind apart from what we've already discussed as they use AI in their processes?
Always be mindful in using third-party AI tools for what level of secrecy you have with them. Does your AI provider provide a wall around your queries and output with a guarantee that no one other than you will ever access them? Some may not. Do you have a non-disclosure agreement with your AI provider? You probably don't. If there is no legal and technological mechanism in place to wall off the flow of information from your input to the AI provider, then your searches, your AI queries are not trade secrets. And anything that AI spits back to you is not a trade secret because you have not taken legal steps to guarantee that the information does not end up in the hands of anyone outside the organization. Also, any data breaches, any exposure that may happen on the side of the AI provider, you don't get a mulligan for that. If your queries or AI's output to you somehow gets out in the public through no fault of your own, you just lost the patent rights associated with what got published, unless you took Craig's favorite piece of advice and filed a provisional patent application on it before you ever accessed the AI. Now, I have a personal theory. I think someday Congress will go back and look at this and say, you know what, this 200-year-old law on inventorship isn't good anymore, and other countries are innovating with AI. It doesn't help the United States to penalize our inventors for using AI. So I think eventually it will change. Maybe not soon, because Politicians don't run on a platform of patent reform. It's not an exciting issue, but I do think eventually it will change. But for the time being, all we can do is play by the rules. And it's the responsibility of people like me to make sure that scientists and engineers know the rules.
And do you have any recommendations for companies, some of the big pharmaceutical companies right now who are, as we saw with our previous speaker, who, but that was more on the manufacturing side, but on the discovery side as well, who are using more for cell gene therapy, who are using different AI models to assist them with drug discovery in that area?
It would work very much the same in biologics and cellular biology as it would in hardball organic chemistry and pharmaceutical discovery. Don't ask AI to design a gene for you, but if you have ideas of how the gene would be designed and you would ask AI, which of these is going to be easiest to synthesize? Which of these is going to be expressed most easily in the human ribozyme? Fair question to ask.
That makes sense.
Ideally, file a provisional patent application before you do it.
That should be the headline for today's
That's
session.
my cornerstone piece of advice for almost everything.
Yes.
File a provisional patent application before you do it, and you have a record from the federal government saying this was yours as of blank date. Nobody can break that.
Agreed. All right. Thank you, Craig, for that was really informational. I feel like everyone who works in R&D and drug discovery today has had their eyes open. So I think that was really a really informational bit of advice that you provided. So Ansley, Craig, I don't know if
this is great, Neha. Thank you so much, and again, thank you, Craig, for that phenomenal presentation.
Thank you for having me.
And so we are rounding out this phenomenal symposium, learning a lot about a lot. So everything from AI patented molecules to specialty pharmacy management, and how AI is helping health plans, hospital systems, life science companies really build their platforms to help patients so much better in the future. And another breakthrough company is on board to talk to us today, and looking forward to hearing from Youssef from Indigenous. Youssef, thanks for joining us today. And I think Youssef is out there somewhere in the ether. In the meantime, if anyone has any Q&A, please feel free to lock in some questions and answers about what's going on. And Eugene's got a question about the recordings. Yes, if you join the HITLAB Hub, you'll see all the recordings and transcripts and presentations there. We've got another question from Martin about if you want to use an AI tool for development, where does the line draw? And again, I think we're trying to figure that out, Martin. And please contact Craig directly. You all have his LinkedIn profile in the chat. If you do want more answers to all of your questions about some of the details around patents and trademarks around AI developed devices and molecules and biotechs and cell and gene therapies, then he is a phenomenal resource to go to. And I would recommend you talk to him and get his advice on what you're developing, since obviously the Supreme Court, if you look at their decision on patents and trademarks for music and for other creative works, they have come down and said that's not happening. So this is a major issue for what we're doing in healthcare and life sciences, and literally what you all are doing. A lot of our startup community and research development and community, that these are major issues that people are endeavoring on this. And so now we do have another major announcement coming from another HITLAB validated company, Indigenous. Youssef, good to see you. Thanks for joining us today.
Hey, how you doing? Thanks for having me.
Would love to hear, if you could, before you talk about your major announcement, what's coming down the line with Indigenous, if you could give people a little bit of background on yourself and your company, that would be a great way to start.
Yeah, no, appreciate it. Thanks for having me. Youssef Enriquez, founder and CEO of Indigenous Bio. We're a biofintech company looking to drive AI native drug discovery by building the world's most representative genomic data set in the world, including women in the African diaspora. We have been excited in working with HITLABs over the last few months in validating, doing some papers around, what we believe to be one of the leading bioeconomy that will lead the future, genomics and AI. Currently, right now, less than 1% of the entire world has had their whole genome sequenced. And in the next 3 to 4 years, we're excited to see the price come down, but also the fact that sequencing will be the major driver in looking at health outcomes within all community and bringing better medications to market that will service not one subpopulation, but all.
Yeah, it's wonderful and so badly needed. Everyone that we talk to from life sciences development, from any kind of device or molecule, biotech, gene, cell therapy, you name it, they're all talking about this. So really appreciate the hard work that you're doing on this, Youssef. And as you all know, there's a major announcement that Youssef has. Maybe you could dive into that a little bit, Youssef, about what your company's doing and who's joining your company now.
Yeah, no, look, we've been diligent. I think a lot of the work done earlier this year has been able to create the validation and evidence around what we're doing. As you mentioned, there's been a lot of articles that specifically speaks to this. And so we're excited to announce that as of a few days ago, we have now brought Dr. George Church, that is at Harvard University, the Wise Institute, has agreed to join our board because not only does he believe that sequencing costs should come down, as he's been doing over the last 20 years, he now believes that cell and gene therapy should be lower costs for individuals that need it the most within low-income communities. So yeah, we're excited to bring Dr. Church on board, being our scientific advisory board member, along with others that will now really start thinking about how we frame indigenous bio as a company so that we could, meet the needs of so many communities, including myself, that are suffering from rare disease and some cell and gene therapy that'll be able to help eradicate some of the health disparities within communities that are underrepresented.
Youssef, congratulations. I mean, I'm so happy for you and for the whole team at Indigenous. It's such a major announcement. And for those of you that are more on the health tech scene and less on the bioinformatics or on the gene therapy scene, then please just Google George Church. Very easy name to find online, unlike some other names like myself or whatnot. You can easily spell that name. It's literally spelled as it sounds on both names. And just look at the person that we're talking about here. Youssef, again, congratulations. One of the most serious, impactful, and relevant scientists in the work of gene expression and gene research, and certainly gene drug development in the last 50 years. So a really, really major congratulations to you, Youssef.
Thank you. Thank you.
There's another big piece of news as well that some of the community may not have heard about, which is the coverage of the New York Times article in this area. If you could talk a little bit about the New York Times article and a little bit about what Indigenous and how its work is affecting what they talk about in the New York Times article.
Yeah, no, look, you want to say stars are aligning. I mean, spending time with George Church, as you mentioned, getting a walkthrough of what he's working on there at the Wise Institute, inspired me as well to, think more innovative, right? Being around him for a day or two, that could spark a lot of innovation. And so the New York Times article came out timely because it's what Indigenous has been kind of saying over the last couple of years. And then really earlier this year, we were able to do the HITLAB evidence report with HITLAB. So kind of really flesh that out is that, again, great science is being done, but there has been a subpopulation that's really driving a lot of the medicines, right? So that 88%, the missing 88% that we did really spoke to this New York Times, where we're now seeing the outcomes of that, right? So what the New York Times highlighted was the fact that a lot of the genetic testing that are being done are representative of what's being used, which is European descent data. And so currently, the New York Times article really kind of flushed out the polygenic risk score, which is one of the, the earliest innovation part that's been coming out along with pharmacogenomics. But, it's what Indigenous has been saying. How can we be getting the precision medicine and personalized medicine if we know the numbers are skewed the way they are? And so I think all the New York Times article did was validate what HITLAB has already validated, and what Indigenous built the company solely on, is that we need better representation of the GWAS research that's being done, because this is the end result, that we're going to have all of these novel cell and gene therapy, whether on the cell side or the gene side, that are going to be a little bit skewed to European descent, and that's not truly going to be representative of just what the US or the globe is. So, again, a little bit disappointed with the fact that, we are here, but there lies the opportunity of what Indigenous is building, because we're now seeing the evidence, not just on the research side, but downstream, when we're seeing that these genetic testing that's being utilized today, not 20 years ago, not 30 years ago, but today, has this, disproportionate amount of European descent data that's driving cell and gene therapy. And that should be a concern for everyone going forward as we move into personalized and precision medicine.
Yeah, talk a little bit more about that as well. Let's double click on that personalized and precision medicine component of what you're building. Again, just the headline here, guys, is not just the coverage in the New York Times article about what they're doing, but also the George Church addition to the team. I think it's important just to understand the novelty and the relevance of what you're developing, particularly in light of the FDA's stance on diversity of genetic sets for drug development, disease prediction. Over the last year, they've come down pretty strong in saying that, yeah, if you want to have something approved, it's going to have a diverse set of clinical data in each phase, which includes a lot of the use of, particularly if folks are trying to do virtual or simulated trials, they have to have that data. And you've got now the largest data set in the world for the African genome. So talk a little bit about how this, like you said, all of these converging forces are coming together, and how that's impacting what you guys are doing around disease prediction and drug development.
Yeah, no, look, being a former FDA guy, policies are important, right? And so, not only are we seeing this as good science, and the science is there, now we're seeing that the policy, slow over the last couple of years since, when this originally started a few years ago, of looking at phase 1, 2, 3 trials. But we're starting to see bipartisan support of that. This is just good science, because it's not that Indigenous is trying to create a African genome repository that's only going to benefit the African diaspora. It's already shown statistically like 40 to 50% genetic variability increase when you sequence more individual from a representative genome pool. And so that's women from all backgrounds, Black, white, Chinese, and then, of course, the African diaspora, which has been historically known to have higher genetic variability. So, again, we're excited also on that regulatory tailwind, that we're starting to see bipartisan support on what's just been good science. This is not diversity thing. This is not a black and white thing. This is just saying, hey, we have this amount of people in the world. We need to do precision and personalized medicine. However, we don't have a data set today that represents that. And so we're also excited, not only with having George Church help us lead some of the initiatives that we're going to be doing in this space, but also that we're building a repository that will be representative. And so we've spent a lot of time building relationships on the continent, also here in the US, to have access to over, 1 million African descent genome whole blood sample ready for sequencing. And so, we're in the process of working with HITLAB in order to start driving, investor interest, so that we could definitely look at the opportunities on how to scale fast and have this data readily available for academic researchers, startup companies are like ourselves, so that we could drive better drug, cell and gene therapy for the future.
That's exactly where this is going. And I think the The other thing that people need to know about and hear about directly from you is part of what we did in our validation around the data governance and the ethical use of AI. Talk more about how Indigenous is driving that with your business model and with the team that you're assembling. Obviously, having George Church as a part of that team is another piece of evidence validating that you do have one of the highest ethical data governance structures out there for this kind of work with gene data. If you could go into some detail for our audience here.
Yeah, no, look, as a former FDA guy, you know, my colleagues and peers are also keeping a close eye on this. So my time at FDA spent a lot of time around making sure that we're collecting the samples ethically, and of course, making sure that the data governance is there. Of course, as you know, large data set like this will require partners. So we've been very diligent in working with our tech team and partners, which is Oracle, so that we could have the infrastructure and the GPUs and the compute power in order to really, one, store this data, sequence the data, but also protect the data, which is also going to be a critical component for some of the underrepresented population that is going to ask some of the tough questions. So what we've done is we've built out a tech model working with Oracle. We've built out a clinical genomic insight engine. We've written a patent on that particular technology that we filed last November, which includes being able to encompass the safety and the privacy that's required. Our CTO, Eric Williams, used to work for Johnson & Johnson and Tata Consulting, has spent his diligence and time over the last year creating a clinical genomic insight engine technology platform that we know will be robust as we scale to take on large terabytes of data and be able to withstand from an interoperability standpoint, be interoperable with other data systems that's already out there, but underrepresented with the data set that we're looking to do. So, over the last 6 months, we've spent a lot of time working with tech team. So we make sure that we have a data set that we could ingest with clinical data along with your genomic data so that we could come up with the best drivers of how to personalize medicine for each individual on our platform. And so in October of this year, we're looking to have the first MVP, which contract was signed a few months ago, where we have an MVP for a trusted research environment for South Africa, where we're helping them curate about 7 countries consortium where they have about 150,000 of the HIV, TB, malaria, PEPFAR samples that requires a trusted research environment that's protected in order to do data query and drive medicines that could help HIV, TB, and malaria development, drug vaccine, and gene therapy in the future.
That's incredible. And congratulations on that agreement as well, Yusuf. You guys have a lot of good stuff going on, and we're really excited to be teamed up with you to help in the overall validation and acceleration of your diffusion into the ecosystem. We've got a few minutes left here. One last question, which is, we've got a lot of startups, a lot of investors, a lot of healthcare buyers listening to this program today, hundreds around the world, thousands, and over the next month we'll hear this. If you could talk about some of the lessons learned that you've come together. Again, you're not new to this game. You've got a storied career, not only in the military, but with the FDA. And now you're bringing it all to bear to help not just the world, but also your daughters. If you could talk a little bit about the lessons you've learned in building Indigenous and in building this extraordinarily ethical AI governance within Indigenous as well, and what you'd like to pass on to some of the investors, buyers, and builders at HITLAB and in the community around the world.
Yeah, no, look, great question. One, I think, listen, it's a unique opportunity, right? We see everything that's going on within the world. Policies are being changed. And so, I'm excited in the opportunities that's out there to bring innovation to the forefront, which I think is also where I think the breakthrough you'll see from individual groups that are looking to challenge some of the health disparities and the rare disease that are affecting millions of people. For me, again, not only am I a founder, but I'm also a dad of twin girls that's suffering from a rare genetic condition called retinitis pigmentosa, and they're losing their vision. And so this is important for me to, one, have a data set that represents, the globe, but also, two, making sure that the privacy and security is also included. But it's tough. You could drive the market scraping data that's already out there, but if you already know that that data set does not represent the population that you're trying to drive the cell and gene therapy, that's already, a non-starter for us. And so we've taken the time, like I said, working with HITLAB to make sure that we had the evidence and the validation studies to move forward, but then also making sure that we're building this with the trust of the community that we're looking to engage. So knowing some of the history that has happened over the century, we wanted to make sure that we're getting early customer engagement, which we've done over the last couple of years, building buy-in with communities, especially rare disease, sickle cell, diabetic retinopathy, and some of those areas that have seen a large uptick in prevalence. And so, what we've been doing is in community engagement, right? Boots on the ground, education, training, health literacy. Those are all things, because these are still emerging technology, genomics, AI, machine learning, blockchain. These are all things that are still fairly new. And so we see that the importance of making sure that we don't rush to having a product on the market before we've truly understood some of the complication or why this has not been done at scale before. Because remember, this is an area pharmaceutical companies are still struggling with billions of dollars. And so Indigenous has been very meticulous about getting that buy-in and building the trust in the community that we want to make sure that this then is rapidly scaled once we've built that foundation. And so truly been a delight to work with HITLabs, of thinking about all the things that could come up and will come up in the future. And so as we start to move into our infrastructure raise around capital, we're now starting to build that engine that we're going to start being able to show the data and the results that we know will come from having a diverse and representative genome data set that could end up driving medicine for a globe.
That's great. Yusuf, again, thank you so much for all the good work you're doing, not just for your daughters and for the country, but for everyone around the world. And looking forward to seeing you back on the program again soon. Take care.
Appreciate it. Thanks for your time.
So there you have it, everyone. An extraordinary day with an extraordinary session. Don't forget to sign up for the HITLab Summit in December 1, 2, and 3, as well as the Symposium, the Centers of Excellence, whether it's Breakthrough Alliance for New Companies, Women's Health Tech for Women's Health Companies, or the Center for AI Testing and Evidence. We'd love to see you in those hubs and working with people like Yusuf and working with people like Build Toronto, et cetera. And then don't forget to also register for the Symposium next month. Again, a lot of, just a ton of evidence coming out on rural transformation, the $50 billion that the federal government's put aside for that, $25 billion still left. We'll talk about where the funding can be found and where it's going, and hear from all these great folks from all up and down the healthcare system. Thank you again to all the great folks from HITLab, whether it's Rachel Ansley or Raymond, Pallavi, Melissa, Jerry, Nico, and Rijo. We appreciate all you guys do to put these programs on every month. And again, join the HITLab Hub to help these programs continue going. Your support is critical. At least make sure you're subscribed to our LinkedIn, Instagram, Facebook, Twitter, and YouTube accounts to help support the community there. And thank you to all of our partners and sponsors who are all over the world helping promote evidence-first digital health adoption. Until then, you guys, we'll talk to you later. Take care. Have a good month. Bye-bye.